Shall we start?
Sure.
Good evening, all. Welcome to the last day of National CME Smriti Tarangam on pediatric epilepsy. Today, we have two sessions. First session will be carried out by Dr. Roshni Anirudhan, Professor and HOD, Department of Kaumarabhrithya, Government Ayurveda College, Trivandrum, on the topic From Basics to Clinical Interpretation of EEG. And the final session will be carried out by Dr. Robert Matthew, neurologist, Anugraham Neurocare Center, Trivandrum, on the topic Approach to a Child with Seizure. So, we are about to start our first session by Dr. Roshni Anirudhan. For that, I would like to welcome you, ma'am. Dr. Roshni Anirudhan completed her UG and PG from Government Ayurveda College, Trivandrum, and PhD in Childhood Autism in 2020 from Kerala University. She has 21 years of clinical experience in managing various pediatric cases. She also won various awards, including Atreya Award. Now, I welcome Dr. Roshni ma'am to start today's session.
Thank you. Good evening, one and all. Today we are on to the last day of Smriti Tarangam. So until now we haven't covered that the basic investigation of seizure disorder, that's EEG. So I thought today we'll be covering the basics of EEG and also the clinical interpretation before going into the class from the expert neurologist at Trivandrum. So is the screen visible?
Yes, madam. Visible.
Yes, ma'am.
Okay. So, EEG is the baseline investigation for any seizure disorder. If you are suspecting any seizure disorder, to investigate the severity of the seizure, to rule out like seizure mimics, or is it a migrainous aura, or if the baby is having a psychological disorder, or it's a non-seizure episode it's better that it's a first line investigation to be done in a suspected case of seizure. So hats off to the great scientist Hans Berger, who has invented this investigation. He noted that the cortical pyramidal neurons, they are arranged in layers, and this movement of the ions is creating an open field in the brain, and this tons and thousands of these neurons, when arranged in a similar line, can produce these electrical signals which can be recorded through highly sophisticated channels. So at first it was an analog EEG. Now after all this development, we have a digital EEG, almost popular in all the centers. Analog EEG was the older type, which had a bundle of EEG papers which need to be written, and it was a bit more tedious procedure. Now this digital EEG is common everywhere, so it can easily store and transfer the data. So we can keep it in the EEG findings can be kept in the memory for long as well. So portable EEG machines are also available. So the components are, it has a head box. Head box is that part of the EEG which has the shape of a human head on that, and a specific dotted points are also noted in that, and from the dotted points that electrodes are being connected. So it is an ADC, that's analog to digital converter is the, and a computer screen. A photic stimulator is the, photic stimulator is a light source attached to that seen on the extreme left top of the EEG machine. It is producing a light in a special in a typical pattern. And also a video camera is usually attached if we are planning for a video EEG, so that we can record that clinical body movements of the baby along with recording the EEG events as well. So to give up an idea of the basics of EEG, it depends upon that electrodes and where the electrodes are placed. So standard EEG machines are following a 10-20 system, where this is the aerial view of the skull, and that extreme is that nose or nasion, and the posterior extreme is the inion, and on the both sides it's a auricle or ear placed. So this complete area of the skull, viewed on the aerial view, is divided into in certain parts, and each electrode is supposed to be placed on that. We'll see how it is placed. So this is the international 1020 system. So here this it's a nasion, that is the depression on above, just below that uh, palpebral fissure, and this is a nasion, and this anteroposterior diameter is taken, and also this circumference is taken, and it's divided into parts. So 1020, the name came from the uh, that way where we place the electrodes. In certain electrodes are placed at a distance of 10% distance from the nasion. Then the next electrode placed in 20% distance, and so on. So that's the name is like 1020 system. So we'll just have a quick click on how the electrodes are placed, because it will be giving us an idea while reading an EEG, that we should have an idea in mind that from where this abnormal electrical discharge is coming. So this is an aerial view of the skull with nasion, inion on the back, on the posterior, and both ears, auricles on the either side. So we'll be taking the circumference of the head, total circumference of the head, touching the nasion, the auricles, inion, and like this. And the total circumference will be, and an interjunction point will be marked between that anteroposterior and the lateral circumference. And this point will be marked as CZ. Z means on the middle. So CZ means central sulcus area representing the central sulcus. So the name CZ. So if we have a total circumference of the head circumference as 50 centimeter, so the 10% of it counts for 5 centimeter. So from the nasion, we will give a gap of 5 centimeter that accounts for the 10%, and mark a point just beneath that. That is the first point. That mark another point just posterior to that, that is 20%. That is almost 10 centimeter after this first point. And that is how the other 2 points are also marked. First point, 5 centimeter above that inion, and the next point 10 centimeter above. So we got 4 points, and we name all these 4 points as FZ, that is a frontal lobe and in the central sagittal sulcus, and this PZ, that is parietal lobe and the sagittal sulcus. And the other way, the next 2 points on the lateral side. Just lateral to the sagittal sulcus, we have another 2 points on the right side, and also next 2 points on the left side. So those points will be marked as C3 and T3 on the left side. All these left-sided points will be having odd numbers. So the C3 will be representing the central sulcus on the left side, while C4 will be representing the central sulcus on the right side. Similarly, T3 will be representing the temporal lobe on the left side, because 3 is an odd number, so it corresponds to the left side. The counterpart will be T4 on the right side. The next points will be on the periphery, that is this will be the extreme frontal pole is this. So FP2 FP representing the frontal pole. FP2 2 means it's an even number, so from the right compartment, right side of the brain. Again, F8 on the next point. F8 is actually representing the anterior part of the temporal lobe. So it's not actually connected with the frontal, even though the name comes as F8. It's the anterior part of the temporal lobe. So next point is T6, that is posterior part of the temporal lobe, and O2, that is representing the right occipital lobe. So similarly, the counterpart on the left will be FP1, as similar to FP2, that is frontal pole on the left side. Then F7, that is left-sided anterior temporal lobe. Then T3, we have T5, that is posterior temporal on the left, and O1 corresponding to the left occipital. So another two more point, that is F3 on the left and F4 on the right. Similar to C3 and C4, we have the frontal lobe here and the anterior. So F3 on the left and F4 on the right. Another two more points we have. We have the parietal lobe over here. So we have the P3 on the left and P4 on the right. So it's easy to remember that here anterior part is a frontal lobe. So we have F3, FZ. Z means always it's located in the central sulcus, or Z means it's located in the sagittal cut. So F3, FZ and F4 here. C3, CZ and C4 here. P3, PZ and P4 here. And that front two portions are FP1 and FP2, the frontal poles. Then F8, T4, T6, O2. So these all are the points which are which these points are usually standardized. We need not know that distance between them and all, but we should be aware that which area of the brain they are representing. So that FP1 means always odd number indicates it is from the left side of the brain. So FP1 is frontal pole on the left side and the right part is FP2. Similarly, you are knowing that F3 means frontal on the left and the counterpart is F4. So that is how we represent. So everyone should be aware of the points. This is the baseline information one should be knowing about the EEG. So it will be like all these points will be generating, electrodes will be attached to these points, and we are planning to record that electrical data generated from these areas. So these areas, these electrical data will be representing the brain activity on the corresponding area of the brain. A short video of how EEG is being recorded in a child. Usually, if we are suspecting a seizure disorder, it's better that if we can avoid an sedative and do an EEG, it will be the best. It will be giving more information. So, if we are suspecting a seizure, in a suspected case of seizure, it's better do a sleep deprivation EEG. Sleep deprivation means you are depriving the sleep of the child the day before. We are not letting the child to sleep in the day hours and delaying the sleep and the night sleep late like 1 o'clock or midnight, 1 o'clock or 2 o'clock. So the next day morning, the baby will be fast asleep, and we are actually increasing that stress and strain for the brain function. So any minor defects in the brain can be appreciated in the EEG. So this is a sleep deprivation EEG without a sedative. The EEG technician is Venugopal sir. He was working in Sri Chitra Institute for last 30 years. He is having a portable EEG with him. So you can see that suitcase with him carrying the portable EEG. He is fixing the electrical leads from this head box. You can see that head box with him. He is fixing that electrical leads with the help of a gel over that. The electrical gel is very easily conductible, and he can easily pick out the electrical discharges. He is fixing the leads in the 1020 system as we discussed earlier. He's very thorough with that. So no need of measuring and marking all these points for him. This is a gel he's pasting and using a paper plaster to stick it. See, that one was CZ. Yes, completed, covered that left side of the brain, left side of the scalp. No, now he is trying to make the baby place his head on the other side. Thank God he has turned out. So now the baby has turned to the other side. Now he is taking the electrodes on the other right side of the head. See? Yes. Yes, done, almost done that. And now he is with the recording. This is how sleep deprivation EEG is done. You need a very baby friendly therapist or EEG technician for that, to avoid a sedation and do an EEG for him. But usually it's not practically done in EEG centers. But it's the best way of EEG to do. Without an sedative, we can get a raw result of that EEG over there. This is how we have an EEG graph with us. This is an EEG graph. You can see in the left extreme top, you can see that FP2, F4 means frontal pole, 2 means on the right side, connected to F4, frontal right again. And then secondly, that F4, the frontal right is connected to C4. C4 means central sulcus on the right side. Next, this C4 is connected with P4. P4 means parietal right. Again, next the same P4 is connected with O2. So the graphs are given like this. You will be getting a graph like this. So next we need to know how this connection is going on. So 2 electrodes need to be connected in between, and will be recording that electrical difference between these 2 records. So 2 electrodes form actually a channel. When 2 or more electrodes are connected in between, sequentially connected, we call it as a chain. So outside temporal chain means near to that oracle, we have a temporal chain. That will be FP2, F8. We will be discussing it later. So this is a temporal chain. You can see 3 pictures. Please concentrate on the mid picture here, and to see the right extreme temporal connection of chain. We have seen FP2 over there in the frontal pole right. Hope you have seen that frontal pole right. This is being connected to the F8 over that temporal side. F8. Then F8 is connected to T4, that is right temporal. T4 is connected to T6, and T6 is connected to occiput 2, O2. So it's FP2, F8, T4, T6, O2. Hope you are able to see that. So this forms the right temporal chain, that is right-sided temporal chain, from starting from the frontal top, touching that anterior temporal, posterior temporal, and also occipital lobe. So it's a right temporal chain. And again, it's connected, then FP2, another chain starts from FP2, connecting to that F4, just behind that. So it's a just lateral to the sagittal line. So we call it as parasagittal chain. So the right extreme was right temporal chain. Now this right parasagittal chain, just lateral to that sagittal chain. So FP2, F4 is being connected. F4 is being connected to C4, that is right central. C4 connected to P4, and P4 connected to O2. So that's a right parasagittal chain. So we have a chain like on the right temporal chain, that is FP2, F8, T4, T6, O2, and a right parasagittal chain, that is FP2, F4, C4, P4, and O2. When these chains are connected, interconnected, it takes a shape of a banana. And if you connect the left side also similarly, it will see like 2 bananas placed on either side of that sagittal plane. So it will be like we call it as, this connection pattern is called double banana montage. This is the usual pattern which we use in EEG recording. This is called double banana montage. And this connection of chains like right temporal, right parasagittal, left temporal, and left parasagittal and left temporal. It will be in a standard protocol. This is called, this type of series of connection of chains are called, electrodes are called double banana montage, because it seems to be like two bananas on either side. And another connection is, please see the left extreme picture. All these leads are connected to that auricle on the right sided leads are connected to right side auricle, and the left sided leads are connected to left side auricle. Auricle is not having any electrical activity, so it's an inert site. So any connection from this side to that auricle will give that actual picture of that electrical activity over there. So we can call it as, it's not a comparative electrode, it's unipolar. Only one pole is functioning, the other is an inert pole. So this montage is called unipolar montage, because electrical activity is only created from the brain. Auricle is inert. So we can call this as unipolar montage, while this double banana montage is bipolar, because both the leads, both the electrodes are having electrical discharges. So we are connecting one electrically active electrode to another electrical active electrode. So we call it as bipolar montage. That's how we are planned. See the connection pattern in double banana montage, FP2, F8, F8, T4, T4, T6, T6O2. That is right temporal chain. Then next one is FP2, F4, F4, C4, C4, P4, P4O2. So this is the right parasagittal chain. Hope you're familiar with. Then the central chain, that is FZ, CZ, and PZ. That's a central chain. That is sagittal central chain. Then starts FP1, F7, F7, T3, T3, T5, T5, That's a left temporal chain. Then the left parasagittal chain, FP1, F3, C3, P3, O1. So that's a left parasagittal chain. Now it comes the double banana montage. This is, see the shape of the two bananas on either side. So this is how this EEG is being recorded. So this is the actual EEG graph which you see. So then we can see that this is the pattern of double banana montage over here. FP2, F4, F4, C4, C4, P4, P4O2 means this one is right-sided parasagittal chain. So FP1, F3, F3, C3, C3, P3, P3O1 means this one is left-sided parasagittal chain. This is how we know what is going on in the EEG graph. So every time see which montage is that, from which electrode it is getting originated, and then only go and see the graph. See, this is a double banana montage of a child. FP2, F4, F4, C4. See, this is the line. This is the right parasagittal chain here, marked on the right, the red side, red color. Then it's a left parasagittal marked on the black color, and the corresponding waves are there. Then it's a right sided. Then comes FP2, F8, F8, T4, T4, T6, and T6O2. It's a right temporal chain marked on the red side again. So red side means it's coming from the right side of the brain, and black is usually representing the left side of the brain. Many centers will be having a different color code as well. Some centers will be having red and blue, or some interchangeably. Usually red is from the right side. So now we have completed the double banana montage. Now coming to the common reference montage. Is my screen visible?
No, ma'am.
Okay.
Is it visible now?
Yes, ma'am.
Yes.
Now, completing the double Manhattan montage, we are going to the common reference montage. Like unipolar, we told earlier that the montages are that electrical points on the scalp is connected to the corresponding auricle. So it's unipolar. Unipolar means only one pole is active. So it is like right auricle is termed A2 and left auricle is termed A1 as even number from the right side and the odd number from the left side. So FP2A2 means it is directly one electrical point is connected to the right side auricle. So only as one electrode is only functional. So it's actual voltage what we are getting. It's not a comparative study, it's the exact actual recording. So we call it as a reference voltage. For operational conditions, we usually use the paper speed in 30 mm per second, sensitivity. The right upper end of the right top bar of the EEG will be speaking about it, operational control specifications while doing the EEG. As we are not supposed to change that the operational controls usually if you are a doctors, so I won't be speaking much on that. The paper speed should be 30 mm. This is standard operational control. Any deviation from this should be noted. Paper speed should be 30 mm. Sensitivity should be 7.5 millivolt. High frequency filter should be on. High frequency filter means cutting off the electrical discharge from all other electrical devices near the child. Low set at 5 hertz, 50 hertz filter should be there. All these operation controls, I won't be speaking a lot on that. So why we use EEG? EEG is usually used as a evaluation or investigation tool for epilepsy. Moreover, it can be used in assessing that functional status of the brain when affected with the brain tumor, how much the brain functions are altered. You can study an encephalopathy from an EEG regarding the depth of the gliotic area. From that, I'll show the EEG pictures for a gliotic areas and all. We can study about the depth of the infections and regarding that area of the brain involved in case of encephalitis. Also about the stroke and the functional deficits it causes. EEG is actually a functional study. CT and MRI, both these imaging techniques are telling a lot about the structural deficits of the brain, while EEG is speaking us regarding the function of the brain. As being a functional science, Ayurveda is more concerned with functional integrity and functional correction. So more than the structural imaging techniques, especially in a functional disorder like seizure, we are more concerned with EEG. So especially EEG will tell you a lot regarding the sleep disorders and all. You can take EEG as a main tool to differentiate between delirium, seizures, syncopes and all. And even you can use it as a death diagnostic tool, like plain EEG without any electrical activity means it's dead. So, and also you can use EEG as a tool for assessing the prognosis of our management, whether you are apart from the reduction in the clinical seizures, whether this brain activity is bit more better, showing a betterment, and whether the spikes are coming or the seizures are there subclinically also. Actually, the point is we can assess that presence or absence and even severity of the subclinical seizures in the brain with the help of EEG. So as a baseline information, we have to know that there are 4 types of wave generated from the brain. The delta wave is that baseline, very slow wave. When the wave is slow means that frequency is slow. That number of waves per second is low. So see at the delta wave, delta is having at least 1 or 2 or maximum 3 waves in a second. The second means you can see three vertical lines now. This distance between two vertical lines, that is black vertical lines, is 1 second. This 1 second, the distance between two blackish vertical lines divided into 5 again into 5 parts. That is by yellow lines. So this is 1 second, and again it divided into 5 parts, 5 columns. So each one is 200 milliseconds. 1 second means it's 1000 milliseconds. So 1000 millisecond is divided, when divided into 5, it counts like the distance between two yellow lines is 200 milliseconds. Hope I'm clear with. So 1 hertz means how many waves in 1 second. So you can see that in the delta wave, there is only 2 or 3 waves in 1 second. So, but frequency is very low because the number of waves is low. But when the number of waves is low, you can see that amplitude is very high. So delta will be low frequency, high amplitude wave. Delta is that a brain working in a delta wave means it's too low to work with. Then next comes a theta wave. Theta wave is having much more frequency. That is, it's having 4 to 7 hertz. That is like more than 4 hertz. 4 waves will be there in 1 second. And as the frequency is increasing, you can see that amplitude is lowering. So it is much more having more frequency than the delta, but amplitude is less. Now see, now after delta and theta, see the alpha wave, that's top right. Alpha wave is the usual brain wave which we are working. Now I am working in the alpha. Alpha means I am comfortably working. That is usually 8 to 13 hertz waves are coming from in 1 second, and all the amplitude is also bit lower than the theta. But when I'm stressfully working or giving much more concentration and doing it very stressfully, then my brain will be working in beta. Beta is a stressful brain, and it is having more frequency, like about 13. See, it is having lower amplitude, but the frequency is much more. And you can't count the number of waves in 1 second. It's almost more than 15 or so. So stressful brain will be working in beta. So to summarize, usually a brain in an adult brain will be working in alpha. When I am having a stress, I will be working in beta. When I am relaxed and I am sleeping, I will be working in theta. And when I am deep sleep, or I am in comatose stage, I will be working in delta. So the delta is that very indicates a very slow working brain, and alpha means you are in the healthy status, and beta means you are tensed. This is how the normal waves see, like beta on the top, alpha next to that, then theta down, and delta. See, high amplitude, slow waves. And the last one is epileptic spikes. You can see that sharp waves, and over that it's called spikes. It's an indicator of epilepsy. Normally EEG variations are there in children, so you should be like as I told earlier, whenever you see a spike in the EEG, you should be alert. It's an indicator of epilepsy. So every time when you see a spike, that is that sharpened wave over there, it's an indicator of epilepsy. But in children, there are many normal EEG variations over there. So you should be able to plot out that EEG variations also. So I will just give a sketch on that EEG normal variations which are usually found in children. So EEG is usually taken in that sleep and also in the awake form. Below the age of 5 years, it's not taken in the awake, because the awake stage kids below 5 won't be lying with eyes closed and awake, or eyes open and awake. But above the age of 5 years, both sleep record and awake record is taken. So whenever the baby is awake with the eyes closed, you can see that, please see that points which I have marked, that is posterior leads, P4O2, then from the right, P3O1 from the left, this T6O2 from the right, and these 4 posterior leads, that is posterior side of the brain, will be emitting high amplitude waves, and it's called posterior dominance. Please don't count it as a seizure spike. It's a normalcy in children when a baby is awake with eye closed. കണ്ണടച്ചിട്ട് കിടക്കുകയാണെങ്കിൽ with awake with eyes closed, there will be a posterior dominance. It's a normalcy. See how that brain wave is increasing in amplitude when the baby. Now this was a EEG of a child of 3 years. Now see the EEG of a child of 9 years. You can see that background activity, that hurts, everything is increasing in a child when the child is getting mature. So it's indicate EEG also is an index of accounting that brain maturity as well. See the posterior leads as I marked that 4. See there's also posterior dominance. Here the 9-year-old child is lying with the awake with the eyes closed. Whenever we are doing the eyes closed, we are having a posterior dominance. It's not counted as an epilepsy. It's a normal variation. And something to comment upon that frequency of waves and its relation with age. As I told earlier, the frequency of the wave is directly linked with brain maturity. Delta wave means brain is functioning very slowly. So in younger ages, less than 1 year, our brain will be working very slowly. So babies under the age of 1 year will be having more delta waves and a bit of theta waves also. When the baby matures and reaches the ages of 3 years, it will be delta will be very low, and mostly it will be in the theta range. Next range, like 4 to 7 range, it will be more. So mostly in the theta range. So it is saying that brain is maturing, and so naturally the background activity is more frequency it is gaining. And when the baby reaches the age of 5 years, again the brain maturity has increased, and now the background activity is having a bit of alpha rhythm, and it's alpha means 8 to 12 is the alpha rhythm. So it has entered the alpha rhythm. It's just not reaching the 12, but it's somewhere around 8 to 9 hertz. So that is why after 5 years, we are counting that the brain is almost reaching that adult stage, and by the age of 9 years, it is equating. It's easy to remember that by 9 years, the brain wave will be working in 9 hertz. And after 12 years, it's like an adult EEG itself will be working in 10 to 13 hertz. That's perfectly alpha rhythm as ours. So after 12 years, the child EEG is perfectly like adult EEG. So it's easy to remember. 1 year, it's just double or bit more on that. 1 year, it's 3 to 4 hertz. 3 year, it's bit double or bit more. 6 to 7 years. 5 years is somewhere under double, 8 to 9 hertz. And 9 year, it's equated. So it's a brain maturation. This is a picture representation. See the change in the posterior dominant rhythm and also the background activity as the brain matures. See this the brain activity of a 2-year age old child with eye closed. So naturally posterior dominance is there, but not that marked in this younger age because the background is having this alpha. Background is having theta and delta waves. Now it's the next stage, so it is having 3 years, so having more of background with 6 hertz activity is the, and you can see the posterior dominance now clearly. Now the next is if brain is more mature, or the baby is 5 years. See the background activity somewhere now like 9 to 10 hertz, and also you can see the perfect posterior dominance over that. Now, if the baby is awake and lying with the eyes open, and if the awake EEG, always you can see when we are keeping the eyes open, our eyes will flutter, eye blinking will be there. So eye blinking will be causing a contraction of this frontalis muscle, and it will be causing a frontal dip, especially from the leads connected to frontal pole. So FP to F4, frontal pole will be giving a frontal dip, like a dip down. So it's called a frontal dip. This is not a spike, so never should be counted as a spike. This is also a normalcy indicating that our eye is blinking. So this the awake EEG for the first 1, 2, 3 seconds. The baby was lying with the eyes closed. So we are getting the posterior dominance. Then after that, the baby is opening the eyes. So we are getting the frontal dip. Hope I'm clear with. When the posterior dominance is actually absent when the eyes are open, so we call it as alpha rhythm was there in the posterior leads. When it vanishes, we call it as alpha attenuation, nothing more. Then coming the next point, so we have studied about the wake records and that small changes, that is posterior dominance alpha rhythm and also frontal dip there. Now we are coming to that EEG. Usually the EEG will be giving a photic stimulation, as many of the seizures will be stimulated with light. So photic stimulation or hyperventilation will be provided while taking the EEG because they are the powerful stimulators to check whether there is a presence of seizure or not. So what is the change in normal change in the EEG when giving photic stimulation? Like see, this is a photic stimulator on the, it's called stroboscope. It will be flashing the light at the different frequency from 5 to 13 hertz. Usually certain people who are that kappa dominant won't be giving any responses to that bright light. These pitta personalities will be giving more responding to bright light. So kappa personalities, usually they won't be having any effect on this photic stimulation. And a normal photic drive will be there in normal persons. And this photic stimulation can cause seizure attack in different types of EEG. See, this is the EEG representing whenever there is a photic stimulation is given. You can see that I have marked it in a blue box. There is small calibrations on the top of the EEG. You can see now that indicates the baby is put on photic stimulation. Hope you can see that small calibrations on the top, and it's written at 20 hertz. So it is indicated baby is put on photic stimulation at the rate of 20 hertz. And you can see the corresponding EEG variations corresponding in all the leads, but this is a normal response. So it shouldn't be again counted as a spike. It's a normal response. Then coming to hyperventilation. Hyperventilation is usually asking the baby to have a deep breath and ventilate out. Deep breath and ventilate out. So usually as that activity is slowing, our heart rate, everything is slowing. So naturally a slowing of the brain activity will be there. So there will be chances that brain waves are coming down into a delta platform. So this is hyperventilation. That is build-up of theta delta activity. You can see first 2 seconds baby was breathing normal, then we are hyperventilating, so asking the baby to have a deep breath. So the brain alpha waves are being converted to high amplitude delta theta range. Again, this is high amplitude delta theta range with hyperventilation. That's usually the juvenile response, so don't misunderstand it as a spike. Then the drowsy stage. Always seizures attack will be more dominant or more pronounced when the baby is drowsy. That is a transition phase from the awake to the sleep. So whenever a baby, you are suspecting a seizure, you should have a recording in the drowsy stage. Please do the recording when the baby is asleep, and after the sleep EEG, make the baby awake and then do the recording. So in between drowsy stage should be recorded, because allowing them to sleep after an alert stage also is allowed, and that will be giving them that drowsiness will be or seizure will be more dominant in the drowsy stages. So drowsy stage is the most eventful part of the EEG recording. So see, this is a drowsy stage. So we can see the frontal leads, you can ups and down, slow ups and downs in the frontal lead. That is slow eye movement drowsy stage. Again, normalcy, normal recording. You can see we will misinterpret this as spikes, but it's a normal drowsy burst, we call it as. Brain, when switching off from the awake stage to the sleep, has a tendency to have a burst of this delta theta discharges, and we call it as hypnagogic burst or a drowsy burst attack. It's not again seizure, should never be counted. So whenever we see these drowsy burst attacks, make it usually the technician will be giving a underlying statement that the baby was in the drowsy stage. Then different stages of sleep, NREM 1, 2, 3, 4. Usually the 4 stages of sleep will be accounting 60 minutes, and then comes the REM sleep. So total 1 cycle means 4 phases of NREM and 1 REM. So it will be completed in 1.5 hours, 90 minutes. So stage 1, again, normalcy I am speaking about. Stage 1 will be having these vertex waves. Vertex, you can see that vertex waves, usually from the central leads, sagittal leads. Again, second stage will be having sleep spindles. We call it as high amplitude, high frequency waves. We call it as sleep spindles, again normal. Now it's a normal activity, especially in the second stage of NREM sleep. Then pronounced delta theta activity will be the, again, normalcy. Deep sleep in the third phase, again the alpha. When the baby is sleeping, having a deep sleep in the third phase of NREM, the whole brain activity is slowing down and the alpha activity is vanishing. The baby is getting going into that deep delta activity. Delta means brain is slow asleep, delta activity. So 4 phases of the sleep will be showing a vertex sharp wave, a sleep spindle we have seen, and delta activity in these different stages. So I was talking about that normal variations in the EEG, which should be alert about. So coming to abnormal brain activity. So we should be able to diagnose whether it's an epileptic spike or not. Whether it's a spike, it's a poly spike, different spikes coming very nearby, it's a poly spike, or it's a sharp wave alone. We have to differentiate that. Then we should be able to localize from where this electrical active abnormal spike is coming. So that's the origin of seizure we should be able to plot out. And then we should be able to speak whether this seizure is worsening, having a secondary generalization, or it's a focal or a multifocal or generalized. So that we'll be discussing now. So regarding the concept of epileptiform discharges, it's like spike, a slow wave, a spike and a wave, and a multi-spike we are speaking about. So spike means a sharp, high amplitude, very sharp, high amplitude wave, that is called spike. Then slow wave is a broader wave, it's a standalone activity. Whenever there is an epileptiform discharge, we should be sure that that's a standalone abnormal activity in the brain. So if the brain, if it is going synchronous with the normal background activity, it's not counted as a spike or a sharp wave.
Excuse me, ma'am. Your screen is not visible.
Oh, is it? Is it for long it's not visible?
No, ma'am, for this slide.
Okay. Is it visible now?
Yes, ma'am.
Yes, ma'am.
Okay. Now we are talking about the concept of epileptiform discharges. Epileptiform discharges means you should be finding a spike in that. Spike means a sharp, high amplitude, high frequency wave. That is called spike. It's an upward deflection. Upward deflection every time indicates a negative depolarization. And again, a sharp spike and a wave. That is that downwards wave. Sharp spike and a wave following that. The next comes the slow wave. Slow wave is a slow activity. And whenever we are speaking about an epileptiform discharges, these abnormal activity should be a standalone abnormal activity in the brain. It should be not synchronizing with the normal brain activity. I'll show in the actual EEG. This negative phase is actually due to the paroxysmal depolarization. Negative means all that upward spikes are negative activity, depolarization, and then downward activity is actually a positive deflection or hyperpolarization. So a negative phase of paroxysmal depolarization, that's a spike, followed by a large number of neurons are depolarizing. That's why we are getting a spike. Then soon after this spike, there will be a wave due to that hyperpolarization. That's a wave. So a spike and a wave, spike and a wave, it comes like that. It's like a rippling electrical field. So I hope you will be able to see that sharp waves. There's a tendency to have a seizure, but it's not typically a seizure. A spike and a wave discharges, you can see spike, sharp spike and a wave. Then poly spikes, you are able to see a lot number of spikes which are coming in clusters without a wave in between. It is a large number of abnormal electrical gravity. Then a poly spike and a wave you are getting. Whenever you are doubtful whether it's a spike or not, as I told earlier, you count the 1 second time. That is 1 second means, as I told, this time between two vertical lines. Again, it is divided into 5 divisions. That is 1 second means 1000 millisecond. Again, divided into 5 division means one small space between two vertical lines is 1000 divided by 5 is 200 milliseconds. So the spike, for a spike, it should be less than 200 milliseconds, and usually the spike width is usually less than 80 milliseconds. That is how we will be knowing whether it's a spike or a sharp wave. So see the left down. The duration of the spike is usually less than 40 to 80 milliseconds. See the spike and the area which is covering well included coming under that 200 millisecond, and it doesn't occupy more than half of it. So it's a very sharp up, and a sharp wave is much more broader than a spike. So duration is almost 200 milliseconds. The one smaller between two smaller vertical lines, it will be taken. That's a sharp and slow wave. Then poly spike, you can see multiple spikes. So in this EEG, you are able to see the spike here. First coming the spike from P402, it is a spike over there. Then a sharp wave again coming from the P402, and you can see poly spikes also from that. So this is an abnormal EEG, and the focus is, and can you say about the focus? Focus is from the P402, means right parieto-occipital, and also you can see that it's also leads are coming from the right temporal lead as well. So the focus is somewhere around right parieto-temporal region. That is how we comment upon the focus. We see from where the abnormal spike is coming. Now we should be able to localize that spike actually. So it shouldn't be generally an idea. You should be able to locate the focus of the seizure. See, it's a quick review. This is how we have placed the leads, and see if I have a seizure focus on this right parasagittal area marked as the red, which is emitting minus 50 millivolt as the abnormal electrical discharge. So when this electrical discharge is getting transferred to the nearest lead, that is T4, it will be transferring a bit, not the full amount of abnormal electrical discharge. If minus 50 volt was generated, it will be transferring minus 40 millivolt to the nearest lead. And see, to the next lead, minus 20 millivolt, to the next minus 10 millivolt. Similar, as the distance increases, the transferring electrical abnormality will be reduced. So how will we be recording? So this is the right temporal chain which we are speaking about. FP2, F8, T4, F8, T4, T4, T6, T6O2. That's right temporal. And we will be marking about the difference between FP2, that is, it is getting a transferred abnormality of minus 5 millivolt, and difference the other is minus 22. So minus 5 minus 22, it accounts like plus 15. So any positive means it's a downward deflection. So there will be a downward deflection. Hope you're getting that. That is transmitted waves and the difference between the electrical potential between this transmitted. So next, F8 T4 means F8 is working at a potential of minus 20 minus the other is T4 in minus 40. Minus 20 minus minus 40 is plus 20. Again a downward deflection. So next T4 T6, again minus 40 minus minus 10 will be minus 30. So it will be having, as it's minus, it will be having a positive deflection. So similar. See, the upward two leads will be having a downward deflection. The downward two leads will be having an upward deflection. So there will be an intersection area between that upward and the downward deflected areas, and we call that as the focus. And we can say that the focus is somewhere near to that interjunction area. See, the lead will be like this. This is called negative phase reversal. Negative phase reversal means reversal of the phases is seen somewhere here, and the point at which we get the reversal of the phase will be the focus, nearest focus of the seizure. See, so nearest focus will be somewhere here, and the common lead connected is T3. T3 is connected to F7 here, and also T3 is connected to T5 here. So the maximum electrical potential getting is transferred to T3, and so we will be speaking that T3 is the focus of the seizure. So this is called negative phase reversal. Negative phase reversal means both the waves are pointing to you that, see, the seizure focus is in between these two areas. Pointing you that, see, this is the seizure focus. Positive phase reversal means they are going out of this area and it's communicating that it's not a seizure focus. So this, the negative phase reversal, is actually a pointing you to the locus of the seizure. See, another seizure case having a phase reversal here. So both this going out, and now it's T3 is a seizure focus, and this we are getting it from the bi-banana, double banana, bipolar montage, which we spoke earlier. And if you are having a activity like this and it's communicating that it's a negative phase reversal here, most probably T3 will be the seizure focus, but that's an inference we get from the EEG. Do confirm that inference from the other montage, which is there in the later pages of the EEG. That is unipolar referential montage, where T3 is directly connected to the auricle over there. So FP1 connected to A1 or the reference montage will be there. You can see here also T3 is emitting the maximum voltage. So you can be sure that you are confirming your diagnosis that T3 is that focus. Hope it's clear with. See, here another case, FP to F8 is having a negative deflection here. F8 T4 is having a positive deflection. So it's a negative phase reversal. So the locus is somewhere here. The common lead is F8. So the focus is chance that it's an as per the negative phase reversal sign. Focus should be F8. So we should be cross-checking that your inference with the referential lead. Again, here also F8 is having a maximum intensity. So you're confirming your idea that F8 is a focus of the seizure. So anyone can comment on this EEG? What's the main abnormality shown in this EEG? This is frontal eye blink. This is not an abnormal EEG actually. This the main defect is a frontal eye blink. Baby was awake with eye blink. So frontal eye blink is there. But you can see abnormal wave from this P4O2. You can see sharp waves and spikes are there from the P4O2.
Excuse me.
Yeah.
Ma'am,
Right occipital, ma'am. Parietal and right occipital.
Yeah, perfect. P4, right parietal occipital, these spikes and sharp waves are coming. You can see that T6O2 also emitting is the same. So the focus is somewhere like parietal occipital or temporal leads. That is how we should infer. Now another EEG. Can anyone? Spikes are seen on the either side of the brain.
Left central and parietal.
Yeah,
And
left
also
sided
right.
parietal.
And also right.
Yeah, left
There
sided
are
parietal
spikes in.
occipital. Yeah, leads are spikes are coming from left and right P3O2.
Yeah, both.
Yeah, so the focus was there in the left or either on the side, and by the kindling which we were studying about the last class, there's a chance that when the seizure is worsening, when one side of the brain is involved, that focus can spread to the other side of the brain as well. So here the baby is having a kindling effect and both the parietal occipital leads are affected. And so has an involvement of the temporal occipital as well. So this is a kindling effect. See another EEG. Can we try? You can see the phase reversal here. Phase reversal on the right side. One sharp wave is down and other sharp wave is up.
But it is at the last time, ma'am, not at the starting.
No, not at the starting. It's 1, 2, 3,
Yes,
4, 5, 6th second.
6 seconds.
Yeah, 6th second, there is a phase reversal there. It's a phase reversal. And also you can see the occipital dominance. It's a normalcy. It's not a spike. That's occipital dominance. And the spike in the first reversal in C3P4. You can see also the spike reverse phase reversal here. So the focus is C4 and here the focus is P4. This EEG, you can see a phase reversal in 1, 2, 3, 4, 5th second. You can see a phase reversal.
frontal, ma'am. F4 is the common.
F4 is the focus. Perfect. F4 is the focus. And as it's coming from multiple sides, we call it as multifocal. See, this is the EEG of a person, EEG of a child during that, when the baby is having seizure, we are taking an EEG. So we call it as ictal discharge. That is usually found in video EEGs and all. When we are doing the other same EEG also, the other digital EEG also, if the baby is having repeated seizures, we have an ictal EEG discharge. This is an ictal EEG discharge. So abnormal waves are from both bilateral side and it's not generalized. Some waves are not affected. The parietal occipital is not affected. A frontal lobe is not affected. But this F4, C4, P4 are all involved, both on the bilateral. This is ictal discharge. See, the seizure is progressing and the baby is acting ictal discharges. This is another thing to be noted. This is an EEG with a child with encephalopathy. Encephalopathy means it can be a periventricular leukomalacia, baby can be cerebral palsy, or encephalopathy or abnormal brain is the, but seizure activity is not coming. So, as I told earlier, EEG is not only regarding the accounting for the seizure. EEG can give you many much more information regarding how your brain is working. We can comment upon EEG's background is very slow in the delta pattern, means its functional activity is very low. It's not, baby is 9 years, but still the background is working and only in delta, means brain maturation is very less. So you can also comment upon the brain status, that brain functional activity, seeing the EEG. See, this is an EEG of a child with encephalopathy. Brain, very small brain or massive brain pachygyria or some defects like that. This is the EEG. So you can generalize the delta waves you are getting. You are not getting that this child is 9 years and you are not getting 9 years. You should have an EEG frequency of 9 hertz.
9 hertz.
Yeah, 9 hertz. But we are not getting an alpha range here. All round, we are getting a delta range only. So means we should comment that even if the baby is 9 years, his brain is not working at the capacity of 9. It is having a delta activity. So it is somewhere like under the age of 1 year. The brain maturity is only under the age of 1 year. This is usually seen in kids with massive encephalopathies. We call it as frontally dominant, intermittent, rhythmic delta activity. Frontally dominant, intermittent, rhythmic delta activity is going on, and it's not an index of healthy brain. So it's called FIRDA. Frontally dominant, intermittent, rhythmic delta activity is called FIRDA. Whenever you see this slow delta wave throughout the EEG, it's a marker of encephalopathy, and it's not a seizure, but it's a slow working brain in the background. So it's called FIRDA. Again, another EEG. Now we are nearing to that clinical scenarios. You can see a EEG of a child. See the right side, red from the right side of the brain. So it is having very slow waves, while the left side of the brain is working almost normally. Then what will be our inference? Right side of the brain is very slow.
Side of the
Left.
brain is
Yeah, it's a left-sided hemiplegia. Hemiplegia. It doesn't mean that it's hemiplegia. You can strictly comment that right side of the brain is having some encephalopathy and it's giving only slow delta waves over the. You can't even appreciate any theta wave. So left brain is having an encephalopathy. So when the left side is affected, right side is having a encephalopathy. When right side of the brain is affected, so naturally left will be involved. So this is a case of a child with CP. This is not having seizure, but you can comment upon the brain status in the EEG. See the brain. This is the MRI of the child, of the same child. See how this brain is involved. This is how we should relate the MRI with the EEG. And another type of epileptiform abnormality is the usually seen in babies. It's not the spike alone. It is, we call it as PLETs, periodic lateralized epileptiform abnormality, seen like this. Spike is there, but it's very periodic spike, ups and downs also. Usually it's a part of genetic abnormality. So whenever you are seeing a PLETs over the, like it will be a genetic abnormality. Now, see a case. I'll be showing the clinical manifestation and then the EEG. Hope you are able to see the video. Sir. The baby is having a blank stare. Now it is over. It was an absent seizure episode. See the EEG. Whenever there is an absent episode, absent seizure, EEG will be showing very typical finding. As absent seizure is a generalized epilepsy, all the leads will be showing synchronized involvement, and all the leads will be involved, and it's giving 3 hertz spike per second. It's classical diagnosis of absent spike. Once in 1 second duration, we will be getting 3 spikes. So that is a spike level is 3 hertz spike per second. The actually classical diagnosis of absent seizures. Seeing that EEG itself without seeing the clinically seeing the patient, you can diagnose it with an absent seizure. So it is like it's a generalized non-motor absence of or a behavior arrest. Usually this absent seizure will be stimulated by hyperventilation. So if the baby is not having an absent seizure attack during the EEG, make the baby wake up the baby and ask the baby to hyperventilate, ask the baby to take a deep breath, or just ask the baby to blow a piece of paper like this, blowing in a slow speed, and that is how hyperventilation is done. And when or breathe, ask the baby to breathe deep and fast. While doing hyperventilation, usually this absent seizure get pronounced, and that's precipitating the seizure. And then during that awake stage, if we take the record, we can see the typical 3 hertz spike and wave discharges from all leads. So that's a generalized epilepsy. Now another. A case with tonic-clonic seizure, GTCS, generalized tonic-clonic seizure. I couldn't get the video from the pre-seizure phase. Pre-seizure phase was followed by a tonic phase. A tonic phase was with complete rigidity of the body, with tongue biting, everything was After that, respiratory arrest, then stiffness of the complete body was And during that tonic phase, usually defecation and urination happens due to the contraction of the detrusor muscles and all, and are followed by the third phase is clonic phase, which you are seeing in the video, that violent contractions are again followed by post-seizure phase. So for a GTCS to happen, you need 4 phases, that is a pre-seizure phase, a tonic phase, a clonic phase, and a post-seizure phase. As you all know, it's a generalized epilepsy. See, this is a video EEG of a child with tonic-clonic seizure. All the leads will be involved. Because it's a generalized epilepsy, all the leads will be involved. To give a graphical representation, this is not actually EEG. To give a graphical representation, there will be a slowing of the waves in the pre-ictal phase. That's a pre-seizure phase when the baby will be experiencing an aura or a vomiting sensation or a nauseating feeling. Usually in the GTCS, baby will be the kids, it's not the baby. GTCS usually happens in children more than 5 years of age, because for GTCS to happen, it needs brain maturity to give a continuous abnormal discharge for a fixed duration. So GTCS doesn't happen in kids less than 5 years. Usually it doesn't happen. So there will be a pre-seizure phase. Child will be knowing that I am going to have a seizure. So it will be either an aura or a nauseating feeling or a different smell or a tingling sensation or a gastric upset feeling or something like that. Pre-seizure phase, you will get a slowing in the EEG. Then going into the tonic phase, that is stiffness of the muscles, tongue bite and everything. Tonic phase, you will be giving polyspikes, followed by the clonic phase. Again, will be getting spikes, and the post-ictal phase also abnormal discharges will be there. Another child. This is atonic seizure. Atonic seizure. So as I told, typically for absent seizure, similarly, atonic seizure is also having a typical spike pattern, spike and wave pattern. It's 1 to 2 hertz spike and wave pattern, which is seen in atonic seizure. Very prominent spikes from all the leads. That's typical atonic seizure, 1 to 2 hertz spike and wave pattern. This picture you are seeing last day, the seizure provoked with hyperventilation. Sorry, photic stimulation. Hope you remember this. So for analyzing the EEG of this case, we need to do the photic stimulation while doing the EEG. Baby is having an atonic attack while seeing the light. So this is, see, you can see the EEG. On the down, you can see that so very tiny calibrations they have put on, telling you that baby had been hyperventilated here. So during the phase of hyperventilation, actually the EEG variations was not there. And after 2 seconds, slow variation started. That is, a photic response started, but it's not a spike. The brain started responding to the light, but this abnormal electrical discharges, first 2 seconds it was normal, then third, fourth, fifth, sixth, seventh, eighth, it was photic response, normal photic response were given, and after that 8 seconds actual seizure activity is set in. So see, that's the actual seizure activity is coming from the frontal leads. You can see that FP2, F8, that anterior frontal leads are getting involved in all the right and left pattern. This is how we read that photic stimulation response. You can just see the red colored minor calibration on the left side down, indicating that baby was put on photic stimulation, and see that it should read that consequent response after that. Another child. Baby is fully alert, conscious, and is having a focal seizure. Only the hand is involved, and baby is thinking why the hand is going like that. Completely conscious. EEG will be like, it won't be generalized, it is a focal, only the hand is involved. So somewhere from the motor area it is coming. So it is coming from one motor area and having a kindling effect, so that the other bilateral motor area is also getting involved. See? Flexion of the hand, bilateral hand and the head. It's actually salam seizures or myoclonic jerks, which happens usually in West syndrome. West syndrome is actually an intractable epilepsy or epileptic encephalopathy, which we are speaking about yesterday. Some seizures are there, when some epilepsies are there, which are due to the underlying encephalopathy, which is causing an epilepsy, and epilepsy is causing an enormous brain damage. And so that encephalopathy is worsening after every epileptic attack. So it is like a vicious cycle. So West syndrome is the best example of epileptic encephalopathy, and its prevalence is very much more. And the infantile spasm will be so the triad feature of West syndrome is infantile spasm, that salam seizures like that sudden myoclonic seizure, like flexion of the head, neck, and also that flexion of upper limbs will be there, as if we are doing a salam, it will be like that. So it's called salam seizures. And associated with these salam seizures, there will be regression of milestones. Baby will be losing the milestones once he have achieved. Baby will be by the starting of West syndrome, baby will be maybe able to walk and run. Slowly, he will be unable to run, then slowly unable to walk, slowly unable to sit, and slowly all the milestones will be regressing. So, epileptic spasms or salam seizures will be the onset will be somewhere around 1 year, and usually regression and mental retardation will be associated, and EEG will be having a typical hypsarrhythmic pattern. This is a hypsarrhythmic pattern, typical hypsarrhythmic pattern. An abnormal EEG pattern with high amplitude arrhythmic asynchronous electrical activity consisting of slow and sharp waves and multifocal spikes. There are many focus here. Spikes are coming, abnormal waves are coming from many regions. So it's multifocal origin. So many areas of brain are involved. So this hypsarrhythmia pattern. Hypsarrhythmia means it is high amplitude. Hips means high amplitude. Arrhythmic. No rhythm pattern is found over the hypsarrhythmic pattern is a classical finding of West syndrome. Whenever you see hypsarrhythmic pattern in an EEG, it is sad to comment that it's an epileptic encephalopathy with a poor prognosis. So we are summarizing today's presentation. Like whenever we are seeing an EEG, be sure that we should be reading that double banana montage on the first, and later on we should, after inferring that whether it's a normal or abnormal or any spikes over there, then we should be cross matching it with, confirming it with that unipolar referential montage. Usually referential montage will be the last page attached to the EEG. First few pages will be speaking about double banana montage. Make sure that from far, if there are any abnormal leads, abnormal spikes over there, whenever there is you see a spike, whether this rule of negative polarization is working, whether you can locate the focus, be sure on that, and make sure that you are able to plot out that normal variations in that. That is, you had seen that posterior alpha dominance, then frontal dip, frontal eye blink dip, then when the baby is in the drowsy stage and all, high amplitude delta burst was the sleep spindles was there in the NREM sleep, and vertex sharp waves were there. Don't count it as a spike, it should be counted as a normalcy. And see for focal sharp waves, spikes, polyspikes if any, and try to localize that spike if it's whether it's coming from, and if you can see, think whether you can see a phase reversal in the double banana montage, and do have a cross reference with the unipolar referential montage, and be watchful about it, ictal EEG and all. In encephalopathies, be watchful about FIRDAS and PLETs. That is to summarize about the TEG. And I thank everyone for the patient listening. And I know it was a tough session, but a bit on the basic of EEG will help you to have a clinical inference about on prognosis about your EEG cases.
Thank you so much, ma'am, for delivering such an informative session. Now, all the doubts regarding the EEG is now cleared. And now our session is open for Q&A session. The participants are now requested to put their queries in the chat box, or you can unmute yourself and ask directly to the ma'am. If you have any doubts, you can put in the chat box or you can
There
unmute
is
yourself.
other.
You can ask.
Maybe I was bit fast with. Thank you, Reindeer Ratty, madam.
Ma'am, there is one question. Ma'am, how often EEG is repeated to assess the seizure prognosis in epilepsy?
It's nice one. Usually we take an EEG before starting the medication. That's how we do usually. We need to know how the brain is functioning. Not only that, about we should be commenting about the seizure, we should be able to comment upon the base brain activity. So, seeing an EEG, first inference should be how the background activity is. Whether the child is having a background activity similar to the age, whether there is an encephalopathy underlying, and then only comment upon the abnormal activity. So, first background activity should be given an inference and then the abnormal activity. If the baby is having a seizure, for sure, mostly the EEG will be showing a spike. It's not mandatory that all babies having seizures should have an abnormal EEG. Maybe the seizure gravity is very slow that the EEG may not be showing a seizure abnormality. For such cases, we need to stimulate the brain or make the brain tensed and do a sleep EEG and then evaluate. If you are doing a sleep deprivation EEG, then chances are that you can get a pronounced seizure activity in the EEG. So, before handling, and if the baby is having very pronounced seizure activity like 4 or 5 times a day or multiple times a day, no need to have a sleep deprivation EEG. You can directly go for an EEG. So while taking the EEG, do count upon how many the frequency of that abnormal seizure activity, for how frequent it is repeating, like how frequent in 10 seconds, how many time, or in a 1 minute time, how many times the seizure frequency is there, and do comment upon that background activity. Then you are planning your medicines, and usually it's a protocol is that you can repeat the EEG after 6 months. If any abnormality is there, if any seizure outbreaks are very common, you can have an EEG upon the clinical need. Like if you are starting an intervention now and the baby is having a repeated attack after 2 months, then as per the condition demands, you can take the EEG then and there. Otherwise, as a normal protocol, we do have a repeat EEG after 6 months. If the baby is improving, having a reduction in severity and duration, no need to take the EEG even after 6 months. You can wait because the baby is having a very good clinical improvement. So you can wait till 1 year or so, and then have an evaluation of the EEG, and slowly, and if you have a good relation with the pediatric neurologist, or if you are adding your drug as an add-on, you can refer the have an EEG done and then ask for a comment from the pediatric neurologist whether to taper their anti-epileptics or not. We can also have a judgment whether to increase our medicine dose, whether to do another management or so. And if the seizure spikes are too much, it is better. It's giving another implication that you can delay your management of or introducing the excess sneha or sneha svedas. It's better sneha svedas. You can delay in excessive seizure spikes and all, it's not wise to do it's not sneha, it is not wise to do a svedaka. That's also another indication. Usually it is advised to repeat every 6 months. Otherwise, if it's normal, if it's responding, you need to repeat only after 1 year.
Thank you, ma'am.
Thank you.
The question is, when would the child refer for EEG after convulsions episode? Convulsion episode can affect EEG report or not.
During the convulsion episode, if we are having an EEG, it's called ictal record. If we are taking an EEG after that seizure record, we call it as post-ictal record. So if we can have any video EEG means a video camera is attached along with the EEG apparatus, EEG machine. We can consequently, as there is a snap which I showed you. We can see that seizure movements in the child and the consecutive EEG ictal records also. It's not mandatory that EEG should be done after in the post-ictal phase itself. Usually in cases like SSP, that's subsclerotic panencephalitis is the usually SSP is due to encephalitis due to measles. Usually measles, when it affects the kids, can affect the brain and cause panencephalitis. The complete brain will be involved, and it can cause to SSP, subsclerotic panencephalitis. It's a very fatal condition, and there will be recurrent seizure episodes in that, seizures going and going. So in the video EEG also we can do. In the video EEG, it's possible to do the ictal recording, and the other EEG also ictal recording is possible. But it is evident that when a seizure attack is there, it's evident that it will be shown reflected in the EEG. So it's better. I usually prefer to have a post-ictal record so that we can locate the focus and all more precisely.
Our next question is, even in general psychiatric disorders, EEG is one of the common diagnostic protocol. How we can differentiate these waveforms between psychiatric disorders and epileptic disorders?
Yeah, I got the question. Yeah, psychiatric disorders, EEG is speaking about that whether there's an encephalopathy or the background activity. It's not speaking about the spike actually. Spike wave, polyspikes, and sharp waves are linked with epilepsy, and psychiatric abnormality is speaking about the brain activity which the child is having. So, as I told you, we can EEG can comment upon that background activity about the maturity of the brain and all we can go. Like temporal lobe is working in the delta pattern means it's a temporal slowing over that. So that can be a tool in psychiatric disorders. But it's not, we are not looking for the spike or polyspike over that. Waveforms from a psychiatric disorder and epileptic disorder means epileptic disorder, we get a spike and polyspike pattern or a typical hypsarthymic pattern, where in psychiatric disorder, we get a slowing usually. Hope I'm clear with.
Question is, can sedative drugs like midazolam and ectoin can affect an EEG?
Sure. That is why we should know of when the EEG is taken, what medicine the baby is on. So if a baby is kept on midazolam is usually given as nasal sprays and given on ectoin or so, we should be knowing that what the medication is going on, because it's as I told in yesterday's class, these valproate and all, they are increasing the seizure threshold. So we should infer that. It's another example is a baby coming to you in the OP with fever and saying that, doctor, I have given the baby paracetamol. Then you are assessing the fever means it's recording only 100 degree in the auxiliary temperature. Don't regard that. It's with the paracetamol, the baby is having 100 degree, means the actual temperature fever is much more than that. Similarly, here also we have to interpret that with valproate, the baby is having these much spikes. So if you are withdrawing the valproate, the spikes will be much more. That's how we should interpret. So every time when the baby is coming to you with EEG, do have a base information what medicine the baby is on.
Ma'am, our next question is how to differentiate between a febrile convulsion and epilepsy through an EEG?
Usually during a typical febrile episode, as it's not originating from the brain, it won't be having that much abnormal spike and wave discharges. And it's only convulsion is all that shakes is not epilepsy. Typical febrile, as I told yesterday, it's an effort defense mechanism of the body to control the core temperature. So it's not as a result of brain abnormality. So it won't cause that much abnormal electrical discharge in the brain. While epilepsy is an abnormality on the brain with the underlying encephalopathy over there, so it will be giving a spike.
Ma'am, our next question is that in a child of 5 to 6 years age having active GTC with underlying delayed myelination in MRI brain, what should be the treatment plan?
It was supposed to be yesterday's question, I think. Active GTCS means underlying delayed myelination. Then, if the seizure gravity is much more, we should be managing that GTC, giving active management to the seizure episode, and then addressing the delayed myelination over that. So, active GTCS usually, depending upon that dosha predominance over that, then we have to assess that. You have to select the drugs. So, as I told earlier, first do the gut correction, then Rasadhatu correction, then assess the dosha of that stage, whether it is which dosha, if its baby is more hyperactive, having seizure attacks during that when the baby is hungry, or having a seizure attack during photic stimulation and all, it's an indicator of Paitika Apasmara. If it's a Paitika Apasmara, after doing gut correction and Esavas Rodo correction, then go for a Tiktagakradam. Tiktagakradam, Pitta Shamana drugs like Kushmanda Swarasa, then don't give the Kushmanda Swarasa Krida, go give the Tiktagakrida, it's having more Srodha Shodhana capacity. But you can advise drugs like ST, Kushmanda, Shangapushpi, Ashwagandha and all as Churna Kalpana in milder doses. And then you can plan for Shiroleba with this Pitta Shamana properties. The Shirathara you can plan for. You can plan for Yoga Vastis, Mustadi Raja Avanavasti, or an Anilomana drug should be given daily. Then slowly proceed to the Brahmana procedures like or Rasayana, like Kushmanda Swarasakrada. Because this pattern will be addressing both, that is seizure and also that underlying brain pathology. This pattern should be adopted if it's a Pitta dominant Rogavastha. And if it's a Kaba dominant, your protocol should be like Panjagavya Krudam, similar. So another Kaba dominant protocol, yesterday I narrated. So it's not the type of epilepsy decides which drug to choose. It's the dosha variation which decides which drug to choose. And it is commonly noted that during the treatment management protocol itself, the dosha will be having different pictures. So usually in the initial phases, it can be like it's a Pitta dominant stage. And now it is more like Srodha is more, and it can adopt a Kabashamana. So you can even think of changing that drug in between that treatment duration by doing the Vikalpa Samprapti whenever it is required. During every visit, you should do a Vikalpa Samprapti depending upon the features of the child and mark the dosha dominance, and they'll make a variation in the drug. That is how. It's not regarding that EEG we should change the drug dosage. EEG can comment upon whether you are going upon your line of management is perfect, whether your myelination of the child is improving, whether your seizure severity is decreasing. So EEG is helping as a prognostic tool to comment upon your line of management.
Thank you, ma'am. We have one more question. That is there any relation between electroencephalogram and doshic diagnosis?
Sorry, I can't directly comment on that, but there is. A seizure triggered with photic stimulation is a direct indicator of more chance that it's a Paitigapasmara. A seizure triggered with hyperventilation is more indicator of Vadigapasmara. Similar. Uh, a prolonged duration seizure with the GTCS with prolonged duration ictal discharges are an indicator of Kapajapasmara. It's not the EEG can directly link with dosha, but indicator of dosha involvement are sure there in the EEG.
Thank you, ma'am.
I think we skipped 2 questions in the initial phases. Yeah, we covered it.
If there are any further queries, you can now put in the chat box, or you can directly unmute yourself and ask to the ma'am.
We have another session at 8 o'clock. Our team of Smriti Sagaram had meant that the KBN should be having a basic information about that EEG, how to read it. Apart from that command, apart from that interpretation which is attached with the EEG, we should be able to comment upon. Usually the background activity and all, they won't be commenting a lot upon that. They will be giving only a single line inference about the EEG. So we should be able to comment upon what's the background. We should be able to understand that functionality of the brain behind. We should be able to comment upon the severity of seizure, how severe it is. We should be able to comment upon or compare between the 2 EEGs of the same child taken at different intervals, whether the disease is coming down or whether disease is progressing. So that is what we meant with the CEG class. At least able to count about, appreciate the spikes, polyspikes and spike and wave discharges. And we should be able to realize whether our treatment is going in the right direction or wrong, or whether the disease is having a very progressive phase, where when we should be alert about or not. That's what our intention was. And thank you for the patient hearing. And I know I am not that proficient in EEG, but it's my keen effort over years to study the base of EEG. With constant request and all, I got registered under the many expert pediatric neurologists who are entering classes on EEG. That's how we got trained in this, and we bought an EEG machine in our department and hired technicians who are expert in the field of EEG. That technician I showed you in that video EEG, that's Venugopal sir. He was an EEG technician in Sri Chitra Institute of Medical Science for 30 years. He comes to our department on request, and he'll take the EEG and do elaborate the details which is seen on that. And then actually we are able to comment upon what's that abnormality. But in spite of that, we take the help of a pediatric neurologist to have a final comment. That's how we do. Anyway, thank you all for the patient listening. I think we have to wait 5 or 10 minutes for next sessions to start with. Robert Matthew sir, Dr. Robert Matthew sir, neurologist in Trivandrum, will be joining us in very soon to share his experiences with dealing with a child with epilepsy. Thank you.
Thank you, ma'am. Thank you so much. We all know that interpreting EEG is very difficult and it is very difficult even to experts. And ma'am cleared all of our doubts. Thank you so much, ma'am. And now we can wait for arrival of our sir, Dr. Robert Matthew.
If anyone can comment upon or share their knowledge regarding the use of RESA drugs in the management of epilepsy or anything, depending upon their experience, we are happy to hear from you. We in South India, we are not habituated to use that much RESA drugs. Maybe it is clear from our presentation. So anyone proficient in that can comment. It will be very helpful for us too. Like Smriti Rasa or Mahavada Vidvamsani or any drugs like that. Wow.
Hello.
Hello, sir.
Good evening, madam.
Good evening, sir.
അപ്പം ഇപ്പൊ ഏതെങ്കിലും സെഷൻ നടന്നുകൊണ്ടിരിക്കുകയാണോ അതോ ഇതാണോ ഫസ്റ്റ്
സെഷൻ തീർന്നു സർ. ഞങ്ങൾ സാറിന് വേണ്ടി വെയിറ്റ് ചെയ്യാണ്.
സോറി. അപ്പം നമുക്ക് സ്റ്റാർട്ട് ചെയ്യാം. 8 മണിയാണ്.
Sure, sir.
Okay.
Reshma, please introduce.
Now we are moving to our next session by Dr. Robert Matthew, sir. Dr. Robert Matthew, after completing his MBBS, did his DNB in medicine, DM in neurology, and MD in general medicine. He was the former consultant neurologist, SK Hospital, Edappalani, Thiruvananthapuram. He also worked as assistant professor, Department of Neurology, Government Medical College, Thiruvananthapuram. He was the professor and HOD in Neurology, Government Medical College, Alappuzha, and also in Pushpagiri Medical College, Tiruvalla. Presently, he is the consultant neurologist, Anugraha Neurocare Center, Thiruvananthapuram. It's my pleasure to welcome you, sir, to this session and approach to child with seizure, and looking forward to hear from you, sir.
Thank you very much for a very kind and generous introduction, and thank you very much, Roshni madam, for giving me this opportunity to discuss pediatric epilepsy syndromes. So I'll be basically dealing with the syndromes and diagnosis, and I won't go too much into the treatment because treatment may be a little bit of different in both specialties. So I will start. So is there an option of interrupting in case somebody doesn't understand something?
Sure, sir. Mic
okay.
is left open for all.
Okay, okay. So that will be better because I don't know where exactly I should be moving. So if somebody can interrupt in between and direct me, that will be good. So, so I'll straight away go into the topic. I'll try to load the slides. So, so pediatric epilepsy syndromes, there are maybe they are very much different from adult syndromes, and it's evolving into a subspecialty. So pediatric epilepsy itself. So based on the age group, the type of seizures, the clinical features, the response to treatment, all this have some variabilities. So it is different from adult seizures. Okay. So we'll just start with the classification. This is a classification of seizures in general by the International League Against Epilepsy. It can be broadly classified into generalized seizures, focal seizures, and those which are not well characterized. So,
excuse me, sir.
Yeah.
Slide is not moving, sir.
It's not seen.
Yeah, it's the pediatric epilepsy slide which is being displayed now, sir.
Now? It's the same
Still
thing?
the same, still the same, sir.
Same only. Okay, okay, I'll just change. Okay, I'll continue and then I'll change it. Okay, so
Yes.
So generalized seizures, myoclonic seizures. Sorry, generalized seizures basically means that there is a loss of consciousness at the onset of the seizure. That is a rough way of classifying it. And focal seizures means there will be preserved sensory.
Yeah, now it is moving, sir.
It's moving. Okay.
Yeah.
What is slide?
Now it is childhood genetic epilepsy with febrile seizures. Now it is moving. Now the classification is seen, sir.
So is it moving now?
Yeah. Now the classification, ILAE classification is there, sir.
It is. I've changed the slide.
Still the ILAE classification is there on the.
Okay, okay. So now it's changing.
Now it is changing, sir.
Okay, okay. Right. So right. So generalized seizures. So this is a classification. So generalized seizures. The first one will be tonic-clonic. So this is the prototype of generalized epilepsy. There will be a tonic phase where all the limbs will be contracting. This will be lasting for say 1 or 2 minutes, and then there will be a clonic phase where limbs keep on contracting in a clonic way. So jerky movements. This may last for 2 to 3 minutes, and then patient goes into a post-ictal state, or they may sleep off, slumber, and this will last for half an hour to 1 hour, and they recover. This is the common generalized seizure. This is called the tonic-clonic seizure. And there are various types of absent seizures. Absent seizures means the sensorium is just lost, or patient loses awareness and stays unresponsive, and then they become normal and they will have amnesia for whatever has happened during that period. So absence will be, there are different types, and there can be absent seizures with myoclonic jerks. There are myoclonic jerks, means they are just jerky movements involving. Myoclonic jerks can be focal or generalized. So it can involve whole of the body. It can involve single body parts, hand, legs, like that. And eyelid myoclonia. So different combinations of these are seen in different epilepsy syndromes, which we will just touch upon subsequently. And these are all absent seizures, and there are myoclonic seizures, which I've already mentioned. And there are clonic seizures. Generalized clonic seizures means there won't be the tonic phase. There will be just the clonic phase, just the jerky phase will be there. And there are tonic seizures where there will be just a tonic phase. And then they become normal. And there is something called atonic seizures. Now, atonic seizures basically is a situation where the limbs lose the tone suddenly. So when the limbs lose the tone, the body will fall down. So depending upon the severity of the loss of tone, the patient may slowly sit onto the floor or just fall down just like that. Sudden fall also can occur. Or if it's a generalized atonic one, or there may be atonia of the muscles of the neck or specific body parts. So the head may just fall down like that. So these are the generalized seizures. And then there are various types of focal seizures. Focal seizures can be motor. Focal seizures can be where there will be to and fro movement of the hands or the legs or the facial muscles. So usually they are rapid rhythmic movements. Or focal seizures can be of sensory focal seizures. So just a feeling of some numbness which keeps on coming and going. So different types of focal seizures are there. The most important aspect of focal seizure is that the sensorium will be preserved, and the awareness will be preserved during the time. And in certain situations, we may not be able to really classify it also. So we leave it as unknown epileptic spasm. So this is the classification based on the seizure phenomenology. So phenomenology means the way it looks from outside, or the clinical features. So classification of seizures based on the clinical features. We'll go to the next slide. So the slide has changed?
No, sir, it's a classification.
Okay.
Now it has changed, sir.
Right. So is the screen full now?
Screen is not full, sir, but it is visible, sir.
It's visible. Okay. So I just touch upon the definition. There are different definitions. May not be very important operationally, but then for research purpose and all, some definitions are always important. So seizures and epilepsy, even though we use it as synonymous terms, they are slightly different. Seizures means it's the phenomena that we see, the movement, whatever it is, we have just classified, no? They are all seizures. So when seizures occur at least twice, then they can be clubbed and called as an epileptic disease. So there is a slight difference in the terminology. Epilepsy means more than one seizures. So some further clarification and is there, which may not be very important. One unprovoked seizure and a probability of further seizures similar to the general recurrence after 2 unprovoked seizures occurring over the next 10 years. So patient had only one seizure, but there is a high possibility of having next second seizure over the next few years. In that case, even if it is only one seizure, we still label it as epilepsy. And there are a lot of syndromes. Epilepsy syndromes means that let's say there will be a specific type of seizure occurring and accompanying investigatory findings and accompanying EEG changes, specific MRI findings like that. So that is called an epilepsy syndrome. Now I'll make it a little more clear through an example. Let us say a 12-year-old boy had a seizure. So the symptoms were like this. He had an epigastric rising sensation, some uneasiness over the epigastric region, then some chest discomfort, and then patient lost awareness. He doesn't know then what happened. And the relatives noticed that there was a adversive head movement towards the right side. The head was turned towards the right side. There was a staring spell. And then there was tonic contraction of the upper limbs. After a few seconds, patient developed a few clonic jerks. Patient fell down and then got up. So this is the phenomenology. So just to know, can somebody say from where this seizure has originated? Okay. You can hear me, no?
Sure, sir. Sure, we can hear.
Right. So this is actually a seizure that is originated from the temporal lobe. So different seizures originating from different parts of the body will have different features. So this epigastric discomfort, chest discomfort, these are all features of a temporal lobe seizure. So the patient is having a temporal lobe epilepsy. Now, this patient gives a history of febrile seizures. So we are having a 12-year-old boy with temporal lobe seizure, and he gives a history of febrile seizures. And then he was investigated, and he was found to have what is called spikes. We call it a spike and wave discharge. Some changes seen in the EEG over the left temporal lobe. So three things. There was a history of febrile seizure. Patient had one seizure which looked like a, semiology wise, it looked like a seizure from temporal lobe. And the EEG was showing spikes over the left temporal lobe. So three things. And then an MRI scan was done of the brain. And there was a change seen in the MRI in the brain called MTS, mesial temporal sclerosis. So four things. So history of febrile seizure, one episode of temporal lobe epilepsy, EEG showing temporal spikes, and MRI showing MTS. So if these four features come together, so we can say it's a conglomerate of clinical features. So if the four things, if these four come together, we can diagnose an epilepsy syndrome called mesial temporal sclerosis, abbreviated as MTS. So patient has a seizure. There is a past history of febrile seizure and characteristic investigatory finding in the EEG and characteristic investigatory finding in the MRI. So all these four put together, this patient qualifies for MTS. So MTS is a syndrome. But otherwise, the seizure which the patient had was a temporal lobe epilepsy. So these are subtle differences between epilepsy, seizures, and epilepsy syndrome. So when you classify this will be a, we can call it as a focal seizure, which subsequently became a generalized one. So that is the classification. If you analyze this using the first slide. So it's a focal seizure to start with, and then it becomes a generalized one. But if you want to call it as a syndrome, then this becomes a mesial temporal sclerosis. Okay, because there are different types of epilepsies, different types of EEG findings, and different combinations. So always, if you can make a syndromic diagnosis, then the diagnosis will be precise. But in many of the situations, you may not be able to really come to a syndromic diagnosis. then we will just leave it as a generalized epilepsy or a focal epilepsy like that. Okay, so something about epilepsy. When do you say that the patient doesn't have epilepsy? So this is when we diagnose epilepsy. Epilepsy is considered to be resolved in those who had a age-dependent epilepsy syndrome but are now past the applicable age. So I'll come to this first one. Second one, those who are remaining seizure-free for the last 10 years with no medicines for the last 5 years. So the first part of the table shows when to diagnose epilepsy. And the second part tells you when to say patient doesn't have epilepsy. So I'll explain. I'm very sure that you might have heard of the condition called febrile seizures. Febrile seizures occurs in children, usually from the age 6 months to 5.5 years, and it is characterized by fever with seizures. And it occurs, it has a tendency to come again and again, and usually it doesn't come after 5.5 years of age. So let us say we have diagnosed febrile seizure in a patient. But once the patient grows beyond this 5.5 years of age, then it is considered that the febrile seizure is resolved. He cannot have it anymore. So that is the first point. They have an age-dependent epilepsy syndrome, but now they are past the applicable age. And the second thing, patient had seizures and patient was given medicine, and for the last 10 years, he is not having seizures. So he took medicine for 5 years. And then for the next 5 years, he didn't take medicine. Still, the epilepsy did not come back. So without epilepsy for 10 years, of which 5 years is without medicine. So these are the situations where you call that the epilepsy is really resolved or cured. So I'll just try to turn, I think it's not visible now. Okay. Right. Okay. So this is the classification. This is the epilepsy syndromes. So first I had told different types of seizures. Now different syndromes. So each syndrome is diagnosed based on clinical features, electrographic features, and imaging features. So we won't go into the details at all. It is not at all important for regular practice, but definitely important for research. So I put these slides just to impress upon you that there are a lot of syndromes, and many of the syndromes are specific for specific age. So let us say for neonate, immediately after birth, there is a benign familial neonatal epilepsy and early myoclonic epilepsy, encephalopathy, and Ohtahara syndrome. Ohtahara syndrome means they get very frequent seizures. So each one will have its own clinical and EEG characteristics, which I won't be discussing in detail. So now epilepsy of syndromes of infancy. This West syndrome, just remember, West syndrome is a very bad type of epilepsy which doesn't really respond to treatment. So you tend to see a lot of West syndrome patients. Then others I'll just skip. Now these are epileptic syndromes of childhood. Just I would like to highlight one or two So this benign epilepsy with centrotemporal spikes called BECTS, and this Lennox-Gastaut syndrome. Just keep these in mind. We won't go into. So there are different epilepsy syndromes at different age groups. Just remember that. And adolescence. So juvenile absence epilepsy, juvenile myoclonic epilepsy, epilepsy with generalized tonic-clonic seizures alone, all these things are there. And then there are less specific. These are certain epilepsies which doesn't occur in any specific age group. It occurs otherwise also, in any age group for that matter. Okay, so just to impress the point that epilepsy syndromes are varied. So they all manifest as, they will all have seizures only. But when you closely analyze a seizure, some will be generalized, some will have some focal origins in some specific areas, and they will have associated features on investigation. And these different syndromes, they behave differently. They respond to different types of anti-epileptic medications, etc. So epileptologists, basically any epilepsy they see, they immediately classify it into one of these syndromes. So once the epilepsy is classified into a syndrome, then treatment becomes very easy, prognostication becomes easy, like that. Okay, so hope you got the basic concept and list of epilepsy syndromes seen in the pediatric age group. Right. So far we have been dealing with epilepsy and epilepsy syndromes. Is the slide changed or?
Still in the syndromic.
Okay.
Now it has changed,
Yes. Okay. So now we'll come to certain diseases that may mimic childhood epilepsy. It's so let me just ask one question. How do we diagnose epilepsy? So it's from history, or it's from examination, or it's from investigation, or it's from all of this. Can somebody give an answer? Madam, you are told that this is open to all, no?
Yeah, open to all, sir. Answer is coming in chat box, sir.
Oh, chat box.
It's from all of this that we make a diagnosis, sir.
Okay. So let me see the chat box. I'll just access it because I just chat box. Okay, I'll access it. So the slide is visible now.
Yes, sir.
Okay. Okay. So these are the mimics of epilepsy, which is very, very important because the treatment of mimics and treatment of epilepsy are grossly different. Slide എനിക്ക് എങ്ങനെ ഇടയ്ക്കിടയ്ക്ക് ചാറ്റ് ബോക്സ് ആണ് വരുന്നത്? Okay. All of this. Right. Only two I have responded. Anyway, all of this. Okay, so it is true. It's diagnosed by all of this. So now you are seeing the slides, or?
Slides are visible, sir, but the size is bit reduced, sir.
Reduced. Okay. Okay. So somebody has written parents' history or video can help in diagnosis. Nitin has written. Any other opinion? Some more? No, how many of 94 are there? No? Okay. അപ്പോൾ ഇതെങ്ങനെ ഇനി ഇത് മിനിമൈസ് ചെയ്യണം. ഇനി ഇത് വലുതാക്കണമെങ്കിൽ ചാർട്ട് ഓക്കെ. അപ്പോൾ ഇതിനി വലുതാക്കണം എങ്ങനെ? Okay. It is true, but by and large, it is like this. When we examine the majority of the seizures, I'll be discussing this later on also. Majority of the seizures, when you examine the patient, examination will be normal. And when you do investigation also will be normal. So basically, we are diagnosing heavily dependent on the history. I think Dr. Surya Narayanan has come close to this. Some cases can be based history, some okay, right. So majority is based on history. We never get a chance to see a seizure right in front of us, and most of the investigations, in many of the cases, investigations will be negative. So by interviewing the witness, that's the most important. So if I am asked, how do you diagnose epilepsy? So now this is the era of handheld camera, video cameras in mobile and all. So home mobiles may help, but by and large, even today, the diagnosis of epilepsy is basically dependent on history and heavily dependent on history. So many of these mimics also, it is not based on investigation that we'll have to differentiate. We'll have to differentiate again, analyzing the history. And now there is something called video EEG also. So patient will be videoed and patient will be EEG'd the same time. So it's done in the video EEG lab. So we'll come to that during investigations. So these are the mimics. Patient can have syncope and they can have some jerks. So that is called a reflex anoxic seizure. Syncope itself, patient will be just falling unconscious. The commonest example will be during the assembly, during school days. Children will be standing under the sun for quite some time. Some of them might not have taken anything for breakfast and they just fall down. So that's all syncope. And there's something called breath holding attacks. And patient can have cardiac arrhythmias, heartbeat variability, and then they can fall. So cardiogenic syncope. There is something called cataplexy, which is a sleep-related abnormality. Suddenly, with some sounds, patient falls reflexively. So I am viewing the chat box. So please put in your queries so that I can answer it as I proceed. And they can have just staring attacks. There's something called tic disorder. So it's a big list. So whenever we see a patient with epilepsy, these differential diagnosis also has to be considered, because many of these differential conditions doesn't really warrant the long-term treatment which seizures warrant, number one. And number two, many of these are very, very benign conditions and the prognosis is much, much better than seizures. So always we'll have to keep in mind the differential diagnosis of epilepsies and try to sort it out. So I have shown a list. Does is any of these diseases familiar to somebody here? Can you put a message? if there is a disease which is familiar to you from this list. Okay, I think nobody. Right, okay. So I'll go to the next slide. This is little complicated. This just lists out various syndromes at various age group. We'll just skip this. Did you see the slide? No. Oh, very good. Cyanotic breath holding spells. It's fairly common in children, and you are familiar with that. Good. Okay. So I won't enlarge this. I'll be changing this. Tics, very good. Okay. Tics are very common. Tics are all very benign conditions when compared to seizures. So you should not be diagnosing a patient with tics as epilepsy and putting him on medicine for epilepsy. Means treatment is for minimum of 2 years. In some situations, it's 1 year. So it's important that you make a proper diagnosis. Good. So this is for the different epilepsy syndromes that can occur in first year of life. I'll skip this. So have the slide changed?
Yes, sir.
Yes. Okay. So this is again seizures in the first month of life. Different types are there. We won't go into the details. And okay. So these are the causes of epilepsy in children and neonates. I think just I'll keep the slide little last. So these are based on the frequency. These are different causes of acute etiology. Acute etiology means there's a severe insult to the brain producing seizures. Is there anything in this list that is familiar to you? These are all various causes. Okay, comment. No, my comment box is in my iPad. I'm using another device for comment. And this is actually fully open in my laptop.
But for us, it is too small, sir.
Is it? Okay. Oh, sorry.
And the comment box is open in that picture with what we see, sir.
Right,
Now it is bit more bigger, sir.
Now
Now it's bit more bigger, but the slide is not in the full view, sir.
Oh, right.
It's not that readable.
Okay. I'll just correct it. So now this is not readable, is it?
It's better than, sir, before.
So I'll just quickly go through the list. Bacterial meningitis, cerebral dysgenesis, cerebral infarction, drug withdrawal, familial neonatal seizures, GLUT1 deficiency, herpes simplex, hypoxic ischemic encephalopathy, intraventricular subarachnoid hemorrhage, metabolic disorders, vitamin responsive seizures. ഇതിൽ ഫുള്ളാണെങ്കിൽ അവർക്ക് നേരെ കാണാൻ പറ്റില്ല. അപ്പോൾ ഇവനെ ക്ലോസ് ചെയ്തേ പറ്റുള്ളൂ. How is it now?
It is almost the same, sir, but it's better than before, sir.
ഇത് ഫുള്ളായിട്ട് കാണാൻ പറ്റുന്നില്ല.
Hypoxic ischemic encephalopathy we are very familiar with, sir.
Okay, very good. Okay.
Then metabolic disorders like HERLA we get to manage, sir.
Right. Okay. Right.
Then now the slide has changed, sir. It's a different slide.
I'll come back. Now
it is the.
And it's full or?
It's not full, sir, but it's readable.
Uh,
Post-meningitis sequelae we are familiar with, sir. Post-encephalitic sequelae.
Okay.
Then cerebral dysgenesis and pachygyria, corpus callosum agenesis and all we are familiar with, sir.
So most of these you are familiar.
Yeah, we don't get the acute case manifestation, sir.
But right.
Sequelae we get, sir.
Correct. So now the slide is full.
Now it is enlarged, but it's not visible, sir. That corners have went off. Now the left side is visible. Now the left side is not clear, sir.
And left side is not clear.
Now it's better. Now it's better, sir. Better, sir. Far better.
Okay.
Subarachnoid hemorrhage, intraventricular bleeds. After that acute case, sir, acute stage, we get the case.
Right. Okay. So I think. Okay. So most of this should be familiar. Okay. So these are just a list of the common types of seizures. So now we'll go into one or two specific situations. So febrile seizures. So this is the definition. Slide is visible?
Yes, sir, it's visible.
Okay. So febrile seizure is defined as a seizure occurring in association with a febrile illness in the absence of a CNS infection or electrolyte imbalance in children older than 1 month of age without prior afebrile seizure. So it is above 1 month. Usually it is for up to 5.5 to 6 years. So this is the definition of febrile seizure. So I think this is a familiar one, and febrile seizures are important because they are very benign ones and they don't need long-term treatment. You don't have to treat these patients with anti-epileptics. So this is further definition, but this may not be important for us. This is okay. So in febrile seizures, you don't need too much of investigations, and you don't need to put the patient on long-term anti-epileptics. But if the seizure is continuing, if it's a prolonged seizure, then it has to be terminated. So I just thought I'll talk about this because I don't know how frequently you are seeing febrile seizures. This is something which is not to be worried too much about and doesn't need too much of investigation and treatment. Okay, so that is one example of a seizure, an epileptic syndrome. Now I'll go to this Lennox-Gastaut. You have heard of this term name?
Yes, sir. LGS we are familiar with, sir.
Yes, because LGS is one situation where patient gets continuous seizures and it doesn't respond to usual drug treatment. So they keep on coming to the hospital again and again. So Lennox-Gastaut syndrome. So I'll just leave it there. I won't go into the details. Now something about the diagnosis of epilepsy. So I've already, you have seen the new slide? Diagnosis?
Yes, sir. Now the diagnosis slide is on.
Okay. So as I've already mentioned, the ictal semiology, what happens during the seizure, that's the most important thing. And ictal semiology is usually you get the details through history taking from the witness, the person who has witnessed. But of course, the observers, the one who witnesses the seizure may not be focusing on all the details. In most of the situations, the witness will be somebody who is a relative of the patient and he'll be terrified and he doesn't know what to do. And certain things they will observe, and the seizure may be only for 1 minute, but the witness may feel that it went on for 10 minutes in their agony. So the information which we get from a witness may not be the same, of the same accuracy in all witnesses or all observers. And of late, home videos have come up, especially where patients who are having frequent seizures. The observers are, they have a presence, some of them will have the presence of mind. to shoot it so that we can analyze and come to conclusions. So that's the most important part. Then we'll have to ask about the provoking factors, like did the Rashi Jaiswal has asked febrile seizures seen frequently. Yes, okay, it's seen fairly frequently. So with home videos will help, and you'll have to ask about the provoking factors. Was the patient sleep deprived? Was the patient having a fever? Was there a background for hypoglycemia? Like that. You'll have to ask about any illnesses which the patient is having. Did the patient have a stroke during earlier age? Then the seizure is because of that. And clinical situation. And we'll have to also ask about the family history. So is there a family history of seizures? Anybody in the family with seizure, and what was the type of seizure? Like that. So so these factors, these are all clinical clinical, mostly history dependent points from which, by which we make a diagnosis. So okay. So so making a diagnosis after the first seizure is not very easy, and there are studies which say that there's 35% discordance. So if all the doctors make the same diagnosis, it is 0% discordance. So but in reality, there's, as if it is 50% discordance, it means that only half of the doctors who saw the patient are agreeing on seizures. Half are not agreeing. So the discordance can be as high as 35% after the first seizure. So diagnosing epilepsy is not very easy always, especially after the first one. Then subsequently, with multiple seizures, we'll get more information, so the diagnosis becomes more accurate. And the common, I've already shown a list of the non-epileptic events, but the common ones will be syncope, breath holding spell, and psychogenic seizures. So something about the clinical features of these, if you know, then you can make a more accurate diagnosis. Okay, now little about EEG. The most important, which is the most important investigation in epilepsy? So can you give your answer in the box? Most important investigation in epilepsy. Nobody seems to. Yes, very good. Very good, very good. There is one MRI man. Somebody with electrolytes. Okay. The most important is EEG. Most important. Yeah. It's EEG. Now, EEG will help in confirming the diagnosis, and EEG gives us a direction towards the type or the syndrome, epilepsy syndrome also. So, EEG is the most important one. There are different types of EEG. The old one was the 8-channel one. Now we have the 16-channel one, 32-channel, 64-channel, 128. It goes on like that. And the short-term EEG where it is recorded for 40 minutes, and the extended EEG where it is recorded for 2 hours or even more, and the video EEG where the patient sleeps in a room and stays in a room with the electrodes connected, and with the under the video camera surveillance, and whenever the patient gets a seizure, the electrodes will record the EEG and the camera will record the semiology. So and then there are different types of electrode placement. Electrodes are placed over the scalp, surface electrodes, and there is what is called invasive EEG, where electrodes are placed inside the skull close to the brain. Different types. Needle electrodes are placed, grid electrodes, big grid electrodes, peroperative. During surgery, grids are placed and it is recorded. Different types of recording is there. So basically, in 5% of children with no epilepsy, EEG may show epilepsy. So that's called false positive. especially when EEG is taken in migraine and all, it can show epilepsy. But the patient doesn't have epilepsy. So, but more important will be false negative. You take EEG in 100 patients with epilepsy, and the EEG will be positive only in 40. It will be positive in 60 and it may miss 40. But this is from the Western, where high quality EEG is there. Our regular EEG, I would say, will pick up only in 40%. Our EEG will be missing 60%. So if the EEG is normal, it doesn't assure you that patient doesn't have epilepsy. If the EEG is positive, then you know that the patient has epilepsy. But if the EEG is negative, then you cannot say patient doesn't have epilepsy. And the last sentence, high inter-rater variability. So interpretation of EEG or reporting of EEG is variable from consultant to consultant. A lot of difference of opinions there. It's a crude investigation. So you need a basic knowledge of neurology as well as epilepsy to meaningfully report an EEG. I'll just show one or two. Now this is actually showing what is called the left temporal sharp waves. So this patient has temporal lobe epilepsy. So the absence epilepsy you must be familiar with. So suddenly the child loses touch with the surrounding, and say after 10-15 seconds or little more than that, they come back to normalcy like that. So this is the EEG of a child with absence epilepsy. This is an EEG taken during seizures. So this is EEG of a child with what is called a juvenile myoclonic epilepsy, JME. So these are called spikes, polyspikes, and wave discharges. So there are different types of pattern of EEG for different types of epilepsy. I'm showing just so that you'll get a feel of what EEG is like. So the most important investigation is EEG with its diagnostic limits, and then of course MRI. MRI has limited utility, and if there is an MRI lesion, then the chance of the event being epilepsy is more. It doesn't mean that it should be epilepsy, but the chance of that it will be an epilepsy will be more, and it may give a clue to a syndromic diagnosis, which I have already mentioned, the mesial temporal sclerosis. If the MRI shows a mesial temporal lobe changes, then it tells you that it's mesial temporal sclerosis, like that. Okay, so that is something about the investigation. And coming to the prognosis, how far can you treat? 50 to 70%, we can treat to such an extent that they will be able to discontinue the medicine at a later time. And of the remaining 30%, maybe say, let us say 20% will be seizure-free ride-on medicine, and 5% will benefit from epilepsy surgery, and another 5% remains with seizures for prolonged period. So those are the ones which we usually see, the post-encephalitic sequelae, the Lennox-Gastaut syndrome. So they are all bad epilepsies. So they never respond to treatment, and they keep on coming to us again and again, and we try different medicines for them. So this is the prognosis. So 70% can be well cured with medicine, single medicine. I would say up to 90% can be made seizure-free with medications. And so usually medicines have to be taken at least for 1 year. In most of the situations, we'll have to take the medicine at least for 2 years. So this is in a nutshell about epilepsy syndromes, investigations, and treatment. So I'll just give some time for discussion now. So the doubts and all, whatever you want to know, if you can put it in the box or ask me directly, then I'll answer.
So much, sir. Just really a nice interactive session covering all the aspects of pediatric epilepsy, and the participants are now requested to put their queries in the chat box. And sir, there is one question.
Yes,
And
yes, yes. Yes, I saw that. So, what routine investigation should be done with patient on anti-epileptic drug? Actually, many of the newer anti-epileptic drugs doesn't need any routine investigation. Uh, uh, the older ones, some of them, they would produce fall in blood counts. So, maybe period once in a while, once or twice, we'll do the blood count. And some of them may need a liver function monitoring once in a while. But by and large, uh, there are no other routine investigations to be done in patients on the present anti-epileptic drugs. Now, next, how frequent are metabolic seizures in childhood? Uh, they are not very common, but I'm not aware of the real figures. They are uncommon, metabolic seizures, and it's difficult to diagnose them also. They are uncommon. Oh, I'm sorry. I should be asking you and learning from you. Aditya has asked me, what should the Ayurvedic treatment be given to patients of Lennox-Gastaut syndrome? I don't know.
Yes, sir. Sorry, sir.
No problem. In any specific areas which I should expand, I can. Any common problems which you come across in your practice? What commonly and safe in infancy? Okay. Many of the anti-epileptics are present. Many of the anti-epileptics are safe in infancy and childhood. Let us say we'll start from say the old one, phenobarbital and phenytoin sodium and carbamazepine, oxcarbazepine, sodium valproate, and the new ones, topiramate, clobazam, levetiracetam. So many of them are safe in childhood and infancy, and many of them are recommended for use in childhood and infancy. A child with family history of migraine got first episode of headache, took EEG, showed very interesting. Deepa Ravindranath has given a very interesting case. A child with family history of migraine got first episode of headache, took EEG, showed bilateral abnormal epileptiform discharge. In such case, AED is necessary or not? That's a very good question. Two, three very important aspects are to be brought out. A child with a family history of migraine, if the headache of the child also looks like a migraine headache, then you are not supposed to do EEG in that child. So in EEG for that child is an unnecessary investigation. And in one of my slides, I have shown that in 5% of children without epilepsy, you get abnormalities in the EEG. So this is something like that. So this child doesn't need any anti-epileptic treatment. In pre-pubertal girls, there are episodes of epileptic attacks, no any deformity seen in EEG, then what should be the line of treatment? In pre-pubertal girls, if they are getting epileptic attacks, they may need, when you say attacks, it means it's more than one. So most likely, depending upon the type of epilepsy, they will need need a long-term anti-epileptic treatment. That is the line of treatment. I am very sorry because my Ayurveda knowledge is close to zero, except what I have learned from Lakshmi Madam, Anil Sir, and all. So at the moment, I have no idea about drug interactions between Ayurvedic and allopathic medicines. child presenting with myoclonic jerks, but EEG is normal, what should be the treatment protocol? So this EEG normal in epilepsy is very common. As I've already told, even though the Western literature says that EEG is abnormal in 60%, I would say in our setup with our EEG, you get a abnormal EEG only in 40 or 50% of patients. So in another 50%, the decision on treatment is taken based on the clinical features. So the child presenting with myoclonic jerks, so if it is very frequent, and if it's if it is severe enough to make him fall, and if there is history of seizures along with the myoclonic jerks, in such situations, even if the EEG is normal, we may have to put the patient on antiepileptics. But if the myoclonic jerk is very infrequent, getting jerks only during sleep onset, so they are benign myoclonic jerks, then you don't have to treat. So EEG normal doesn't mean that you should not be treating, or you should be treating. So very good questions are being asked, very interesting. So little bit about the first aid, I will say. If you witness a patient having seizure, basically in epilepsy, you don't have to do anything much. If the patient gets seizure in front of you, make sure that the patient doesn't get injured by falling down. Just support the patient and make the patient lie on the floor or on a cot. And if the dress is very tight, try to loosen it. Open some windows so that air will come in. Don't try to physically restrain the patient. Let the patient have the seizures. If there are any sharp objects near the patient, just remove it, because the patient may hit against the object and get injured. And if you feel that the patient is going to bang the head against the ground, keep a pillow there to prevent that. And just leave the patient alone. And usually the seizures will not go for a prolonged period. If it goes for more than 5 minutes, the clonic movements, then you will have to think of taking the patient to hospital. If it is more than 10 minutes, definitely as an emergency, patient has to be taken to hospital and injection has to be given. But majority of the seizures will subside on its own in front of you, so you don't have to do anything as an urgent. Any other doubts? If a cerebral palsy patient is getting seizure only during fever, should we put the child on AED? Okay. So the patient has a cerebral palsy. So we will have to take a decision on the possibility of this being a febrile seizure. Already, the cerebral palsy means there is an injury to the brain. It can still be a febrile seizure, or it can be part of the damaged brain. More than that, when there is a damage to the brain, the chance of the child getting seizure again, or the chance of the child getting epilepsy is very high, unlike a normal person. So in such situations, we may think of starting antiepileptic as a long term. We may usually, for febrile seizures, we don't put the patient on long term antiepileptics. But in the context of a cerebral palsy, even if it is a fever it's a seizure associated with fever, we may seriously think of putting the patient on antiepileptic. Seizure related to behavioral disorders. Okay, so there are different combinations are there. So let us say Lennox-Gastaut syndrome, the one which is familiar to you. These patients will have gross developmental delay, and they will have intellectual developmental delay also. So they will be having a low intelligence. So that is the abnormality in them, and they will have seizures also. At the same time, in some people, following the seizure, they may become little agitated and irritable. And there are a lot of conditions like Lennox-Gastaut syndrome, where patient will have a lot of behavioral abnormalities, and along with that, they will have seizures also. So some of the medicines given for seizures may help the behavioral abnormalities to some extent, and some others may not really help. And in some, there is something called forced normalization. Patient will have behavioral abnormality, but once they get a seizure, then the behavioral abnormality may improve. So there are different combinations. So it's very interesting. Good doubts are being asked. So there is something called status epilepticus. So status epilepticus means patient gets seizures continues. Usually it gets over in 5 minutes. They keep on getting seizures. So that's a life-threatening situation. Status epilepticus means patient has to be treated in the ICU. So multiple injections will be given to contain it, and if nothing occurs, nothing improves the situation, patient may even be given general anesthesia to control the seizures. How to combat long-term side effects of anti-epileptic drugs? Actually, as I've already mentioned, many of the anti-epileptic drugs don't have long-term side effects. So basically, long-term side effect is for a medicine which has a cumulative effect. Cumulative effect means the medicine, if the medicine is not metabolized fully from the body, little bit of it always remains. So every day, patient takes the tablet. Say a patient takes 100 milligrams, and 98 milligrams will be excreted, and 2 milligram stays in the body. So as days goes on, this keeps on accumulating like that. So to start with, it is only 2 milligram. At the end of 1 month, it will be 50 milligrams, and then it becomes 100 milligrams, like that. So that is called a cumulative effect. That is for medicines which are not fully metabolized. But all the anti-epileptics are fully metabolized. So they don't have major cumulative effects. Now, certain anti-epileptics have certain side effects like, let us say, phenobarbital. No, sorry, phenytoin sodium. Eptoin can produce gum hypertrophy. So eptoin can make the skin more coarse. Sodium valproate can produce some hair loss. Sodium valproate can produce weight gain. And sodium valproate can produce tremors. So these symptoms have to be handled on a case by case basis, because it depends. But they are not actually cumulative effect. They are all directly related to the drug exposure, and it is not a side effect that accumulates over years. Any other doubts?
Hope that there is no more queries. Thank you so much, sir, for clarifying all our doubts. And now it's time to wind up the whole. Oh, sir, there is one more question. Sir, can you explain the benefits of ketogenic diet?
Ketogenic diet is found to be of use in patients with intractable epilepsy mostly. So the case selection has to be, case selection is very important because it has to be adhered to very, it's not very easy to have to adhere to the ketogenic diet. So, and it's not needed in all cases. It is definitely of use in very select case of refractory epilepsy. One more question is there. Literature says that behavioral changes and suicidal tendencies are produced in some cases. Yes, it has some medico-legal implications. I don't know how many of you have read the big novel, Karamazov Brothers. Somebody who has read it in this group? Okay, in that there is a murder committed by the villain in an epileptic fit. And there are a couple of situations where high-profile murders have been committed. And in the court, the defendant says that he did it under an epileptic spell like that. It's not very, very common. So behavioral abnormalities can occur as part of epilepsy, but usually it will be very transient and it won't be very much organized. So something they may do impulsively, but not like planning how to commit a murder and doing it and all. Similarly, suicides also. Now, this psychosis and epilepsy are linked in many situations. So there are patients who are having epilepsy, and the same disease that produces epilepsy can produce psychosis also. And some of the medicines taken for psychosis can sort of bring down the threshold for seizures. Some of the and they can get seizures like that, and the seizures can either sort of contain the psychotic behavior transiently, or preceding the seizure, the psychotic behavior may worsen. So that sort of association is there. But when it comes to therapeutics, psychosis has to be treated in its own way, and seizures have to be treated in its own way. So it can coexist in different ways. So I think that is the behavioral changes as a result of epilepsy leading on to suicide is very, very unusual. So we are winding up.
Yes, sir. Thank you so much, sir. Once again, thank you so much. And now it's time to wind up the whole 8-day National CME on pediatric epilepsy. I hope everyone gained a lot of knowledge about epilepsy, its diagnosis, Ayurvedic management, all aspects of pediatric epilepsy. And now it's time to conclude our session. Thanking everyone who attended the session and for making the CME a great success. And now I am wholeheartedly welcoming Dr. Roshni ma'am for concluding the CME. Over to you, ma'am.
Thank you, sir, for the highly informative session. Thanks a lot. And your way of clarifying the doubts is also very, very informative and very elaborate, sir. Thank you once again.
Bye. Thank you very much.
So we are completing the 1 week CME on the pediatric epilepsy management, Smriti Tarangam, and we don't have a formal valedictory function. So, but we are awaiting some comments from the participants to improve ourselves and to plan for the next CMEs and all. So it will be very thankful if someone can comment upon, give a comment upon our Smriti Sakaram series, and can participants come forward and give a comment? Yeah, Dr. Aparna Dilip is on. Please.
Good evening, ma'am. Good evening, all participants. Myself, Dr. Aparna Dilip. I'm a PhD scholar from Department of Kamarapati, All India Institute of Ayurveda. A few months back, like 2 to 3 months back, Roshni ma'am visited our hospital. She had a video session over here. So during the session, our HOD sir, Dr. Rajgopala sir requested ma'am to have a talk with the scholars. So we requested ma'am to give some suggestions, and we had a discussion with ma'am about Abasmara. See, in our institute, we have an exposure of like 120 to 150 patients daily, and out of them, about 4 to 5 cases we used to have the patients of Apasmara. So we didn't had much idea how to deal with them, because I did my PG over here only. So in the course of 4 to 5 years, the patients are coming, but still they are having the seizure attacks. So in this discussion, ma'am came up with the aspects how to deal with the disease, and since then we, with our colleagues and our scholars, we have a new approach to Apasmara. And in this few months, like in 2 to 3 months, we have seen many patients. And they are telling that they are having improvement, like in the course of 3 to 4 months, when they usually used to have this the frequency or episodes of attacks daily or once in a week, it has reduced in a very good manner. So, ma'am has brought the same topic into such an elaborative session. Ma'am has conducted that is like a very good opportunity to the scholars, even for internees, to the researchers, and at the level of practitioners. I think all who have attended the session are now confident enough to deal with a new case, and they would know how to modify the treatment in which they are been seeing in this few throughout the practitioner. So I'm really thankful to ma'am, and I really congratulate the team for conducting such an elaborative session on Apasmara. Thank you, ma'am.
Thank you, Dr. Aparna. And Dr. Sunish Mohan, Associate Professor of Department of Kajilsa, is the from Government Ayurveda College, Trivandrum itself. Sir, please.
Am I audible?
Sure,
Hello?
sure, sir. Sure, sir.
Okay. Respected HOD Department of Kaumara Prithya, Dr. Roshan teacher, other faculties from the same department, PG scholars, and other honorable practitioners, teachers, and students who gathered here in this great platform. Namaste to all. Thank you, Roshni teacher, for giving me an opportunity to share some very few words in this occasion. As I said earlier, I think in many perspectives, it is a great platform. It was a unique and signature event, I think, in the history of Department of Kaumara Prithya, in my opinion. Let me share some observation in this regard one by one. I will say it is a stakeholder-oriented program. As we know, in a classroom, the students are the stakeholders. Here in this platform, the participants are the real backbone of the CME, because there was very nice and active and sincere discussions after each and every session, including the last session by Dr. Robert sir. So in that way, this is very special seminar or CME. And second point regarding the faculty members, all faculties from the day first, Dr. Reena, Dr. Sohini, Dr. Jamal Joseph, Dr. Lakshmi, Dr. Roshan teacher, Dr. Robert, all of them are very talented in their level of knowledge and their skill, and their participation was a true enthusiasm behind this, behind each session. But the surprise element of this seminar was the presence of those alumni, starting from Dr. Prasanna and others. That was a very nice gesture, and that shows the true bondage of Kaumara Bharatiya family. In my opinion, that it was simply awesome. Then the participation from the PG scholars, that too very brilliant. And I observed each and every day, they started each session in a very beautiful way. Congrats to dear students. And finally, the selection of the topic was too professional. I think it was too professional. Epilepsy is a specialty topic, but in another way, it is a true public health issue too. When we considering the epidemiology, more than 70 million people suffering from epilepsy as per epidemiological data. Among this, more than 12 million from India, and 80% of these patients from low and middle income family setup. So it should be learned by each general physician regarding the symptomatology, diagnosis, etc. And I think in that way, Smriti Taranga CME series was a great platform for general practitioner too, in my case, in my personal opinion, in my personal experience. So my wholehearted congratulations to Team Kaumara Pratya, Government Ayurveda College Trivandrum, for conducting such a very nice, innovative CME series. Thank you all. Good night.
Thank you, Dr. Sunishmon sir. Anyone else? Any suggestions regarding improving this CME series, or any suggestions regarding next topic to be selected, or anything you can comment upon? Actually, we had it as a teamwork. We have 6 PG seats every year and 2 PG diploma seats. So we are altogether teaching faculty. We have 6 course over there, but 3 are actually, we are only 3 now. One teacher, Dr. Reenu, she has joined the PG studies. So at present, myself, Dr. Lakshmi and Dr. Sohini are there. And other one seat is vacant over there, waiting for the next PSC appointment. So it's not only we 3, we count it as more, because we have 6 PG seats every year. So it's like 18 PGs with us. They are actually our power to work with. And this CME series was actually a short planning as a part of National Ayurvedic Day celebration. Our principal Dr. J. Madam asked what you are supposed to do for this. So we thought, why don't we share our knowledge and inculcate the knowledge of others in the platform of pediatric epilepsy. That topic selection was also very abrupt, and then went for a name searching, and something related with Smritya Bayo Abasmara means we have to count something like the Smriti, and the EEG way you see coined it like Smriti Tarangam. That's how the name was coined. And then how to execute it was planned. So we had only very limited funds. The fund allocated for the CME was only approximately like 6,000. So we had to find faculties and everything, arrange everything with its limited amount. So we thought we ourselves will be a faculty for 2 or 3 sessions. Then we invited very key personalities who could prepare and be ready for that CME within the short span of 3 or 4 days. That's how we selected the faculty. And we were really blessed to have this faculty is very ready and very prepared before us. And so our team will be thanking Dr. Reena Kulkarni Madam, our own alumni, now working as the professor and head of the department of SDM Bangalore, was our first faculty, sharing about the Ayurvedic viewpoint of pediatric epilepsy. Extremely, we extend our sincere gratitude to Reena Kulkarni madam for this prompt response and preparing this PPT, everything within a very short span of 3 to 4 days. And on official basis, actually, I thank Dr. Sohini and Dr. Lakshmi, my own colleagues, but I do appreciate their work within this short span, all arranging the CME and also preparing the slides, everything within a space of 2 or 3 days. That's also very great. And also the next faculty from outside was Dr. Jomon Joseph. He is very clinically an expert in the field of managing neurology. So his classes had a different level of applicability, and his view regarding the management is also very unique. So we, the team of Kamara of Government Ayurveda College Trivandrum, extend our sincere gratitude to you, sir, for Dr. Jomon Joseph, for joining us and sharing your views regarding the management. Then the next external faculty was Dr. Robert Matthews, sir, also, because everyone had a different view, had a view that EEG, seizure management mainly done or done by the modern aspect. So someone should be from the modern neurology should be there. We were searching for pediatric neurology, and we had many pediatric neurologists working hand in hand with us for our collaborative studies and all. As you see also in the research studies, we have many has co-guided us, but it was sad to see that international seminar on pediatric epilepsy, pediatric neurology is going parallelly with this our session in Kerala itself. So our pediatric neurologists who are willing to share with us were not able to come and present in this platform. Otherwise, the session would have had a different perspective. Many answers like drug interaction, the benefits of Ayurvedic treatment when put as an add-on to this would have been explained much more better. But maybe next time they will join us in further CMEs. But this time we were not fortunate to have them with us. But Robert Matthews was good enough to share his knowledge and his outlook regarding the pediatric epilepsy management. Then we are bound to thank the participants. It's due to that active participation of the participants and the great inflow which made that CME a grand success. I was astonished to see that Smriti Sagaram WhatsApp group had almost 800 participants in that. I was astonished to see, and we were actually embarrassed how to handle this crowd. But like 130, like somewhere around 120 and 130 participants were so regular in all the CMEs. And we will be thanking you in terms of the certificate after counting the attendance also. But we sincerely extend our gratitude to make for each and every participant for making this CME a very grand success with your interactions and all. I have seen many HODs and senior faculties like Dr. Suryanarayanan sir and from Kapal, Dr. Renurati madam on, and I'm so extremely thankful for the presence in all the CME series. I'm not naming each and everyone, but the name seems every day in that participant list. I'm so happy to see and hope we have benefited from this session. So on official grounds, and I thank my PGs from the bottom of heart for making everything in very short span of time. That is preparing that flyer, circulating it, everything everywhere, and preparing for that introductory remarks and everything. They worked hand in hand, and altogether it was a nice experience for us and a nice learning platform for us too. For again, let us learn together. Let us meet in another platform. maybe with another subject. And thank you once again for this participation. And as a government Ayurveda college Trivandrum, we didn't have the G Suite platform free with us, so we had shared the G Suite platform from government Ayurveda college Kannu. So I am extremely thankful for that college also for sharing this online link for us and online platform G Suite for us. Thanking one and all once again for this making the CME a grand success. Thank you. Good night, take care, and hope we meet soon with another topic.